Spare the Uterus, Judicious, Caesarean section, and Hysterectomy, the need of the hour, organized by NEIGRIHMS in collaboration with ICOG-FOGSI and Shillong Society. Now, I would like to request the dignitaries to please come up to the dais. Firstly, I would like to call Director Dr. Nalin Mehta sir, who is the chief guest of today's CME, to please come up to the dais, and I would request Dr. Ananya ma'am to please felicitate sir. Now, I would like to call Dean Dr. A. Santa Singh sir to please come up to the dais and request Ananya ma'am to please felicitate sir. Now, I would like to call the Chairperson of ICOG, Dr. Parul Kodawala sir, to please come up to the stage, and I would request Ananya ma'am to felicitate sir. I would request the President of Shillong Society, Dr. Shalina ma'am, to please come up to the dais, and Dr. Ananya ma'am to felicitate ma'am. I request now Dr. Ananya ma'am to please take her seat on the dais, and Dr. Juprika ma'am to felicitate Ananya ma'am. Now, we will formally inaugurate our CME by lamp lighting, and would like to request the dignitaries to come forward to light the lamp, and I would also request Dr. Sonal Kodawala ma'am to also join the lamp lighting ma'am. I'll now request Dr. Ananya ma'am to kindly give the welcome speech.
Respected Director Sir, Dean Sir, President, Shillong Society Society, Dr. Shailenia, our guest faculties, Dr. Parul Koddawala Sir and Dr. Sonal Koddawala Ma'am, other delegates of the Shillong Society, Sandhar Sir and Marina Sheila Ma'am, all NEIGRIHMS faculties who are present here, and my dear residents, ladies and gentlemen, a very good afternoon and a warm welcome to you all. It gives me immense pleasure and pride to host the event, the CME, which is on Spare the Uterus, and we are to do a judicious cesarean section and a judicious hysterectomy. And the event will be, it is at NEIGRIHMS Shillong, and the guest faculty is none other than our Chairperson of Indian College of Obstetrics and Gynecology, which is an academic wing of our prestigious association FOGSI, Dr. Parul Koddawala Sir, and the program has been organized in association with Shillong Obstetrics and Gynecology Society, and it has been awarded 2 ICOG CME credit points. We have also arranged for a live streaming through YouTube. And let me tell our online viewers, if you have any queries, any comments, to please put it in the comment box. We'll be addressing them all. We'll be asking to our speakers. So I hope you get the maximum out of this academic event. Thank you all.
Thank you, ma'am. I would like to call the President, Shillong Obstetrics and Gynecology Society, Dr. Shailenia ma'am, to give her speech.
A very good afternoon to each and every one of you. Respected Director Sir, distinguished guests, my seniors and colleagues. I bring greetings to you from the Shillong Obstetrics and Gynecology Society. I welcome Dr. Parul Koddawala to our pristine and beautiful Meghalaya. The CME today is Spare the Uterus, which is in sync with Preserve the Uterus campaign by our parent body, the Federation of Obstetrics and Gynecology Societies of India. Now, the question of excessive or indiscriminate hysterectomies that are being done in the country came to light when the problem in Beed, Maharashtra, where there was, in 2019, there's a lot of, there was reports and it was known that there was a lot of indiscriminate hysterectomies that are being done there. And with that, this had been brought, the problem had been brought forward, and our parent body, FOGSI, had launched the campaign Preserve the Uterus. In the scenario of Meghalaya, we have very less hysterectomies. Hysterectomies in one data that I have learned about is it's about less than 1%. However, having said this, still hysterectomies that have come to be because of AUBO, according to the Palm-Cohen classification, is one of the commonest causes, and AUBO can actually be treated by medical means or by the use of LNG IUS, which can save the uterus. So, this kind of a CME that has been organized by the Obs and Gynae Society, Obs and Gynae Department of NEIGRIHMS is well applauded, and we thank them for giving the CME so that our knowledge is enhanced, our treatment is up to date, and our patients are benefited. With this, I thank you. Thank you very much.
Thank you so much, ma'am. Now I would like to call the Chairperson, ICOG, Dr. Parul Kodawala sir, to say a few words.
The schedule it is later.
So just 2 words.
Well, I am indeed very happy to be this part of country, which I have never been to before. You have a beautiful city with beautiful weather. And thank you, Dr. Ananya, for making it possible. She was recently with us in Ahmedabad for a conference, prior to that in Baroda. And so we could work out for this. And I'm sure it is both the presentations which we are making will be more of a dialogue, and we would prefer to have an interaction rather than a one-way talk or something like that. And thank you once again for asking me to be part of this program.
Thank you, sir. Now I'd like to call Dean Dr. A. Sanderson sir to say a few words.
Chief guest of today's function, respected Director Professor Nalin Mehta, ICOG President Parul Kodawala, President of the Shillong FOGSI Society, Dr. Selena, Organizing Secretary today, Professor. First time I am addressing Ananya. She got just promotion 2 days back, and retrospectively she will be Professor from the 2023. And my dear all the colleagues, my dear resident, our senior most gynecologist in the Shillong and the founder member of the Shillong FOGSI Society, Dr. Sam, Dr. Sila, Jutpi, and then Dr. Lingra, Jaya Misa, all those my resident and the Madam Resource Person, again Kodawala, all the way coming from far away to beautiful place, Shillong. So I am very, very happy to be part of this here. And the topic was very interesting, that the judicious indication for this hysterectomy as well as the cesarean section. So we always apprehension why the cesarean rate is also rising. And at the same time, the government also thinking that only always blaming today obstetrician, but then how the obstetricians are facing the society, because the society also changing. And during our student time, more of the mother care. Nowadays we have to take so much care for baby also. So indications are changing, and that's why indication. And patients are also very litigating. So if anything goes wrong, so doctor has to be always sweating in there. Also, this topic they have taken out. So I'm very happy that understanding part of our obstetrician as well as the gynecologist and with the public and how to deal with it. So I know that from this deliberation and from the resource person we can learn a lot. Thank you so much for inviting me, Dr. Ananya, and congratulations for doing this. And of course the Shillong FOGSI Gynecological Society. Thank you so much.
Thank you so much, sir. I would now like to call Director Dr. Nalin Mehta sir to say a few words.
Thank you. A very good afternoon to the distinguished guests and my faculty colleagues on the dais, the luminaries of the dais. It's indeed a pleasure to have you all over here. My special thanks to the Kodawalas for having spared time to be here, and to our resource persons. I am very tickled by the topic and impressed by the fact that this topic should have been taken up. And kudos to the organizers for paying attention apart from just the word judicious, the connotations of indiscriminate sections, surgeries, hysterectomies are multifold. They are a medico-social issue. We need to realize that whenever a surgery is undertaken without proper indication, or even if it can be justified but it is not judiciously undertaken, it involves a lot of resources. The hospital resources, which we are not a very affluent nation. Many of our healthcare setups are cash strapped. We can ill afford wasting resources where they are not required, and then probably some important surgery or some important treatment, intervention or procedure would suffer because of lack of funds. So this is also affecting the resource allocations, priority setting, as well as the expenses. And the second issue, which to me is of paramount importance, whenever you subject a lady, the pillar of a household, to a surgery that will make her stay in the hospital longer than is required, and in the process also increase considerably the morbidity and the possibility of mortality, which is totally unjustified. And in those terms, the family suffers. So I am extremely happy that we are discussing this topic, not only for the sake of academics, but also as a message to just about everybody. And the Dean mentioned that the patients are extremely aware these days of their rights, and everybody is a master on Google. A lot of them actually can ask you, was this actually necessary or not? The number of litigations are rising. It does not require us to be careful to avoid litigation. It requires us to be ethical. It requires us to be judicious in the use of our resources and in the service of the people, and respect their bodies and not mutilate them. So I would request the organizers and the guest speakers to not only indulge in a very fruitful discussion, but also make a very strong recommendation to the gynecologists across the nation, because you belong to a very powerful organization, that such practices are best avoided. And I'm happy to note when Madam said that in Meghalaya we have a very low percentage. So congratulations on that. So ladies and gentlemen, wishing you the very best for a very fruitful discussion, and I hope you enjoy your discussion, the deliberations, and of course your stay in Shillong. Thank you all so much. Jai Hind. God bless.
Thank you so much, sir, for your enlightening words. Now I would like to call Dr. Ananya ma'am for a vote of thanks.
Good afternoon once again. I thank the Almighty for giving me such a wonderful opportunity to be a part of this scientific event. I'd like to extend my heartfelt gratitude to our chief guest, Director NEIGRIHMS, Professor Dr. Nalin Mehta sir, for being here with us. You have always inspired us, sir. My sincere thanks also goes to Dean NEIGRIHMS and our head of the department for his guidance and support all throughout. I also would like to thank Dr. Shailenia, our President Shillong OBGYN Gynae Society, for her support. Would thank the Secretary Shillong OBGYN Gynae Society also, who couldn't make it today, and all other esteemed members of Shillong Society. Special thanks to Samdhar sir and Marina Sheila ma'am, who have taken out time to be with us. My heartfelt thanks goes to Dr. Parul Koddawala sir and Dr. Sonal Koddawala ma'am, who have come all the way from Ahmedabad for the event. I thank each faculty from NEIGRIHMS who are present here, and my very dear PG students and residents, without which the event would not have been possible. I thank the academic, pharma partners, telemedicine staff, photographer, the caterers, and all other supporting staff whom I might have missed. Thank you one and all.
Thank you so much, ma'am. Now I would like to request our dignitaries to please take their seats down. We'll be starting the sessions shortly. I would request all the delegates to collect their certificates before leaving the CME today. Flash. I would like to call the first chairperson of the first session, Dr. Marina Shillong ma'am, to please come up to the dais. Dr. Marina Shillong, she is a retired medical superintendent of Ganesh Das Maternal and Child Hospital, Shillong. I would like to request our second chairperson, Dr. Shalini ma'am, to please come up to the dais. Dr. Shalini ma'am, she is presently serving as President Shillong OBGYN Society. She has served in various rural and paramilitary forces for a period of 14 years. She is presently visiting consultant in Bethany and Woodland Hospital. She is the faculty in various regional and national conferences. She is the member of organizing committee in ICOG-FOGSI, NEOGISCON and North in IAGE, and her area of interest is high-risk pregnancy. I would now like to hand over the dais to the chairpersons. I would like to hand over the dais to the chairperson and introduce Dr. Ananya ma'am, who is the first speaker of the session.
in my slides. Let them introduce you. Stay here. No, you put this one. You stand here.
Good afternoon, all. Welcome to the first session, and it will be taken up by Professor Dr. Alina Das. She's a professor now in NEIGRIHMS with more than 50 years of undergraduate and postgraduate teaching and examiner experience. She's a recipient of the CS Drama Award, the Talent Award, Dr. Devi Yamuna Singh Award, Champions Award, and she has more than 75 publications from credit. She's contributed to FOGSI ICOG, GCPR, ICOGs. She is an invited faculty for many international, national, and regional conferences. He is co-coordinator for Inauguration from
You can change.
she's involved in many projects in policy changing trials with ICMR, EDT, and INCLEN International. Also, the symposium speaker in ICOG-FOGSI 2024 at South Korea. We'd like to give the time to Alina.
Thank you so much, ma'am, for that kind introduction. We will be starting with the presentation. Now, people say when emotions get linked to thinking, it doesn't become rational. But I would say it doesn't happen that way. Emotions give a better dimension when it is properly placed and in play. Then it gives a better dimension, and actually it works. You get more of relevance in thinking, and you do a more of rational thinking. So now in the next approximately 20 to 30 minutes, I'll be taking you through the topic of spare the uterus, and would try to think and believe that yes, there is a need to spare the uterus. Right from repair, from a cut which has occurred during cesarean section, to removal of the uterus in a hysterectomy. So here we go. Now, these news items these are newsworthy, these are noteworthy as well. Now, what happens is, whenever we come across such news item, it does raise eyebrows, right? Now, what happens next is we try to delve deeper into the matter. We try to reach out to the statistics, the facts and figures which are connected with this. Now, after that only we are going to believe it. Now, this figure shows the rate of cesarean sections right from 2005-06 to 2019-21, and this is NFHS data 3 to 5, wherein we can see those red zones are areas where the cesarean section rates are almost more than 30%, and there is a rise in the rate of cesarean section which are conducting more than 30% cesarean deliveries right from 2005 to 21 over some 15-16 years period. Now, WHO, way back in 1985, they have clearly stated that there is no justification for any region to have a rate higher than 10 to 15%. Now, we should keep in mind that this data has come out from a very limited resource, and that is mainly from the northern European countries that actually demonstrated good maternal and perinatal outcomes otherwise as well. So, 40 years down the line, we cannot really look up to this data and try to find out what's coming up. Cesareans do have complications. Cesarean is also a surgery, and yes, they have complications, both anesthetic and surgical. And over and above, we too have future obstetric implications on that. Because see, once a lady enters with a history of previous cesarean section, so even in this pregnancy, we treat her as high risk. So now we feel this is the time to review and recommend the rates. The concern is over the rising cesarean section rates. We also understand the potential negative consequences on mother and child health, and we do understand the overburdened, the overloaded, exhausted health system, and over that we are putting some significant expenses which might not be required at all. So, Taking all these considerations in mind, WHO conducted 2 studies, a systematic review of available country-level studies that had sought to find the rate, and also a worldwide country-level analysis using the latest available data. But the disappointment is still there. The heart of the challenge was in defining what is the optimal cesarean section rate and at what level. Now, the problem which was there was actually the lack of a reliable and internationally accepted standardized classification system which can actually help us solve the problem. Now, there comes a ray of hope when Dr. Michael Robson in the year 2001 proposed the Robson's classification, which actually stratifies women who undergo cesarean according to their obstetric characteristics. Then we can also draw a comparison of cesarean section rates with fewer confounding factors. So that is what we need. In order to measure, track and compare cesarean section rates over time and between healthcare facilities, WHO also suggests Robson classification system to be in place and its usage, implementation and interpretation so that it can be standardized across the countries. So this is the Robson's classification. We'll see more in details in our coming lectures. It doesn't just end there. Research was still on, and the breakthrough was when in 2014, WHO, after a systematic review, stated that increase in cesarean section rates up to 10 to 15% at the population level are associated with decreases in maternal, neonatal and infant mortality. But above this level, increasing the rate of cesarean section is no longer associated with reduced mortality. Now what? So whatever goes beyond 10 to 15% is of no help in reducing the mortality. A substantial part of the crude association between the CS rate and mortality appears to be explained by the socio-economic factors which are on play. Now, any link between maternal and newborn mortality and rates of cesarean above 30% could not be justified. So when we look at these figures, cesarean section deliveries across India increased from 17.2 to 21.5% when we have looked up to the data from NFHS 4 and NFHS 5. Then again, CS prevalence exceeded 15% in 22 states in NFHS 4, whereas it is in 28 states in NFHS 5. Now here, there's some sort of a good news here that the cesarean section rates are lower in Nagaland and in our state Meghalaya and also in Bihar. Now, these facts and figures, of course, they are eye-openers. But what I believe, the lasting impact is always with a narrative. And that will really help us search for a solution, seek a solution. So what happened is, way back in the year 2016, there was this lady who was 46 years old. And she had an unexpected pregnancy. It was her first child. And she had an extraordinary delivery too. Now, looking at her age, the doctor had advised her to go for a cesarean section. But she, who also happened to know the nitty-gritties of pregnancy and delivery, was determined to at least give a sincere effort for a natural birth before going for surgery. She had confidence in her body and mind. And surprisingly, for almost everyone except herself, she did deliver normally. Now, when I looked into the narrative, I found these words very interesting, which is confidence in her body and mind. Now, had it been from someone else, the cynical doctor in me would have just ignored it. But this doesn't come from someone else. She was the president of the UK's Royal College of Midwives and someone who had been caring for pregnant women and conducting deliveries since 1960s. She then talked about the philosophy of normal birth, about how we need to demedicalize and humanize modern obstetrics. She also said that every childbirth for a woman is a rebirth for herself. Even we find celebrities like Aishwarya Rai and the royals, Kate Middleton, they have also famously opted for natural births. So maybe the same philosophy is getting applied. So now with this narrative, we know that the problems with unnecessary cesarean are multifold. Maternal infection, hemorrhage, infant respiratory distress, non-compliance to breastfeeding, even a longer hospital stay, higher out-of-pocket expenditure, and it puts an unnecessary strain on our overburdened healthcare system as well. Now, these difficulties are getting more difficult because of the disparities in cesarean section rates, which we should be aware of. Otherwise, we won't be able to target those areas, target those localities where actually it is causing a problem. Now, C-section delivery rates in private facilities are in general far higher than those in public hospitals. Even across the country, when they have studied, a recent study analyzed within country wealth-related inequalities in 72 low-middle income countries found that substantial subgroup inequalities do exist. High geographical variability was also noticed in India itself, where the prevalence ranged from 5.2% in Nagaland to more than 60% in Telangana. So you can imagine the disparity. So this is a graph which shows the proportion of CS in public and private sector, where no doubt there is an increase in both the sectors, but private sector is an all-time high. Now, these are certain factors which will be dealt with later in further details that have impact and increase cesarean section rate, age at delivery, obesity, education, and even the demographic factors, the community level factors, the place of delivery, even the mother's beliefs and superstitions have a role in increasing the cesarean section rates. Now, what to do? So, as we know that cesarean section is a very convenient option both for the healthcare provider as well as the mother. But we need to strike a fine balance between this convenience and medical necessity and actually individualize every case and try to justify whether it is actually required or not. To ensure optimal maternal and fetal outcomes, we need to address maternal health, patient education, and medical decision-making processes. Now, the caution remains. CS can cause significant and sometimes permanent complications, disability, even death, particularly in settings where the facilities are lacking. Now, every effort should be made to provide cesarean sections to women in need rather than striving to achieve a specific rate. So, it's not about the number, ladies and gentlemen, it's about the necessity. So, that we need to understand. So, I now come to the second part of my talk. We'll again listen to some narratives from post-hysterectomy ladies and try to understand what is the problem, where is the problem, and seek a solution for it. Now, there's one lady who said, the doctor did tell me about the hysterectomy which is required, but the grief that comes with hysterectomy was never explained to me. Now, for some it was like it seemed so drastic, so final. A lady even felt, was I less of a woman because my body was no longer capable of bringing forth the next generation. There was a pervasive feeling of emptiness because the organ, which is very symbolic of womanhood, has been removed. There were moments of antardvand as well, as we say, because see, somebody who had been suffering from a fibroid, having heavy menses, pain in every cycle of hers, so she was more or less convinced that yes, I need a hysterectomy. But when it actually comes to hysterectomy, and even in her post-hysterectomy days, she does feel that she feels miserable because she really doesn't want to get rid of her uterus. Now, believe me, at any age, no lady wants to get rid of her uterus. At age 41, before the surgery, I said I wouldn't have any more children. Now I had to say I couldn't have any more children. So that really makes a difference. So this is just the mental agony part of it. I mean, I know this is very important, but apart from that, there are many medical disorders, many medical complications which come along with post-hysterectomy. Now, this is a landmark survey, the longitudinal aging study in India, which Lassie Wave 1, which was taken up in 2017 and 18, and the Wave 2 is coming up in 24-25. It was launched by Ministry of Health and Family Welfare, Government of India, in collaboration with International Institute for Population Sciences, Harvard School of Public Health, and University of South California. They had done a full-scale national survey of scientific investigation of the health, economic, social determinants and consequences of population aging in India. They have just looked into every aspect of aging population in India. Now, this LASSI is a nationally representative survey. Over 73,000 older adults aged 45 and above across all states and union territories were part of the study. Now, what is important and why I have quoted it here is because it includes data on a variety of topics, including hysterectomy and women's health. So here we see the graph where they have shown what are the causes of hysterectomy. Now, excessive menstrual bleeding has been a cause in around 30% ladies. Fibroids have been a cause in around 24.2% ladies. Uterine disorder, cancer, uterine prolapse. So these are like known and obvious reasons for hysterectomy. But believe me, apart from that, there's a very significant contribution of unnecessary rampant hysterectomies which are going on and which actually calls for some audit, for some interference from the policymakers. So the prevalence of hysterectomy among women aged more than 45 years was 11.4% according to the survey, with higher odds among urban women and higher economic status. A cross-sectional study also found out that a 36% higher odds of hypertension were found in ladies who had undergone a hysterectomy. Now we know every lady, 1/3 of her lifespan is spent as a postmenopausal lady. Now, if we do an early hysterectomy, we are leading her to a longer postmenopausal phase without estrogen, which may increase the risk of all non-communicable diseases. Now, this graph this picture over here shows the prevalence of hysterectomy amongst women more than 45 years, and here also we can well appreciate that there is a disparity. We can see some states like Punjab and Andhra Pradesh, they actually have a hysterectomy incidence of more than 25%, and which is quite significant. So that is why we really need to know the disparities for hysterectomy so that we can target specific areas and specific reasons for it. Unnecessary hysterectomy is a concern. The community-based studies have consistently found rising hysterectomy rates amongst young women aged 28 to 36 years. The higher risk was amongst the poor because they could be easily motivated, they are less educated. Field-based reports have also suggested that even though there were medical and non-invasive treatment available, which was quite a good substitute, but people had undergone unnecessary hysterectomies. Reports of potential coercion for financial benefit under various health insurance schemes have also been reported, and it needs a special mention here that 2/3 of procedures were conducted in private facilities itself. Now, if we get into more facts and figures, NFHS 4, they said that estimates hysterectomy prevalence to be 3.6% amongst women in the age group 30 to 39 and 9.2% amongst women 40 to 49. The median age at hysterectomy was found to be 37 years. Now, the prevalence, again, I told it greatly varies across states. Telangana, it is around 20 to 23% in ages 40 to 49 years. Now, we all would agree that medical claims have a big contribution in the rising rates of hysterectomy. 2% of claims submitted for women under Ayushman Bharat were for hysterectomy alone. 6 states generated 3/4 of all hysterectomy claims with a median age of only 44 years. Hence, the challenges were identified. There is a need for appropriate clinical and population level guidelines on hysterectomy. There has to be availability of appropriate information right at the primary care level, and of course, a critical need to monitor and regulate the appropriate use of hysterectomy, and therefore the establishment of audit committees at various levels. The aftermath of hysterectomy, we know the mental agony. Apart from that, we have the problems which the lady faces day in, day out with hot flushes, sweating, vaginal dryness, mood swings, osteoporosis, dyslipidemia, cardiovascular disease, stroke, mood changes, vaginal dryness and lack of interest in sex, which affects her sexual life as well, bone loss, heart disease, urinary incontinence. So we all agree here that hysterectomy should always be the last option. Now, the takeaways are: a good surgeon knows how to operate, a better surgeon knows when to operate. But who is the best surgeon? Who knows when not to operate. Decisions are more important than incisions. What I believe is A surgical incision is very technical, but a decision is highly intellectual. So with this, I thank you all. This is a very fond remembrance of my times in ICOG National Conference in Ahmedabad a couple of weeks back. And I thank you all for being here. Thank you, everyone.
Thank you very much, Dr. Ananya. That was really very comprehensive, very enlightening. Thank you very much. I'm sure all of us in the audience have also benefited. Somebody wants to ask a question.
Thank you, ma'am.
First thing I'd like to tell you. First thing, hysterectomy shouldn't necessarily mean surgical menopause. I mean, you have other ways to prevent the surgical menopause, is it not? Like, you spare the ovary, is it?
Yes, ma'am. So what happens here is, even if we spare the ovaries, it does get affected because there are common blood supplies to the ovaries which get compromised while doing hysterectomies. So ovaries are not expected to function the way it was functioning along with uterus. So that is the problem.
So once again, like you have celebrities who are like trying to normalize even prophylactic hysterectomy, let's say for example. So is it not the other way around? You should try to normalize what a person has undergone, like say prophylactic hysterectomy as well, not just the indicated hysterectomy. And something which, like these days, what is not required basically at the moment. Like say, I'm very sure that gynecologists must be going after the family's completed, and after most of the time it does have a valid indication, even the 9% cases which you have seen. And that too is in a higher socio-economic status probably, because in a lower socio-economic status, the person will deal with the endometrial, whatever complications, even endometrial bleeding at the time of perimenopause, rather than just opting for hysterectomy. That would be the last resort for any woman. So once a patient has already decided and given consent for hysterectomy, the effort should actually go in normalizing the situation rather than.
No, what I believe is like, ma'am, the patient will not take a decision on her own. It's always an informed consent we take. Once we supply her with all the information, all the technical details of it, then she takes a decision. And consent most of the time is how the doctor counsels. So just completing the family doesn't mean she is the perfect candidate for hysterectomy. So that way, I mean, normalizing the situation means there are other ways. I think if we don't go for invasive procedure, there are other ways. If we can take care of her disease condition without going in for hysterectomy, we would go for that only. And that would make her remain normal for the rest of her life.
So what you have represented is the last resort.
Of course, ma'am. Of course. Yes, sir, that was my motive actually.
A couple of things I would like to share. One thing was curious, those who have not undergone this had higher hypertension, those who are this life
Yes, sir.
Is there an association? So if you remove the uterus, it is not, is it?
No, actually, sir, we say that estrogen always is a protective hormone. And that is why till the lady remains in her reproductive age, the incidence of stroke, the incidence of heart attack is far less than her male counterpart. So estrogen is very protective, and once menopause sets in, estrogen goes away, and that is how she becomes.
Non-hysterectomy
Is it, sir? Okay.
But hysterectomy also doesn't always mean TH doesn't.
Higher odds of hysterectomy, hypertension than women without a hysterectomy, sir. So with hysterectomy, the incidence is higher. Yes, sir.
Now, when madam asked about the continent, in fact, if you retain the ovary, the menopause comes only 18 months before the expected menopause. also.
Yes, sir.
So till then the effect of historian does continue.
Yes, sir. Of course, we would try to preserve.
RCOG had a survey.
Yes, sir.
That means basically that the hysterectomy patients had the most satisfactory outcomes when they reported that.
Okay.
Other people, other therapies, they had discomfort or dissatisfaction after the period of 2 years, and they report for something as well as our hysterectomy period. Problem is over. But the other things can have a problem, still persist. But that is one point which sometimes people will ask us about. Verify what is the problem, especially 40 plus patients, 45 plus patients. And in our social spectrum, Gujarat, many do not like to give because always that worry of cancer is there in their mind. You can never say them that it is zero. And they are not ready for repeated checkups. That's the issue. So those are few things for this part. Regarding cesarean, I agree that we need to use them. But we have to remove the word normal delivery or natural delivery for vaginal. We can say vaginal birth and cesarean.
Exactly, sir.
Both are words.
Exactly. And even the delivery word should be removed because Zomatos do delivery. Why should women do delivery?
Previously, WHO said anything less than 5% means there is possibility of facility. It is not genuine less cesarean.
Yes.
Anything less than extended to 10%. So places where the rates are less than that, perhaps the facilities are not there and these people move to other place to undergo cesarean section, which is illegal.
Yes, sir.
So that also has to be kept in mind that if Bihar is just 9%, some patients are going to be
Yeah, that will alter the statistics. I agree, sir. I agree. So the message is basically it has to be a very judicious approach to cesarean and hysterectomy. It's not that these are life-saving procedures. There's no doubt about it. It's not that we can get away with cesareans and hysterectomy. Just that we should not be. We have seen patients here even for Bartholin cyst. They have done a hysterectomy in a private setup, sir. So how can we justify that? So that is something.
I just have a comment. Thank you, I think it was very, it was so very interesting talk. And a very interesting question from Dr. Jaya. What you replied was, let us do something abnormal and then normalize it. So I think when it comes to section, any kind of surgery, I'm not saying hysterectomy should not be done or section should not be undertaken. I'm sure they are positive, but it should only be undertaken when it serves the best interest of the patient.
Exactly.
Not for the financial benefits to the corporate sector or to the surgeon who wants either monetary gain or in this prepared till the word that becomes and I will make your meeting with the gentlemen and thank you for making me here and I hope the presentation will continue.
Thank you.
I'd just like to remember regarding the hysterectomy for Bartholin cyst. Hysterectomy was done for Bartholin cyst per se.
Chai. Run, Virangana.
Anybody will do hysterectomy for Bartholin cyst.
I also strongly object on that comment because I think our gynecologists are well aware and they are well updated. And I don't think anyone in this day and age will do a hysterectomy for a Bartholin cyst. So I beg to differ on this. However, I'd like to comment that your presentation was good. And also I would like to say that what you have said about the psychological aspect of cesarean, I think I have faced patients and had patients who come from very elite and petite, but still the elite and petite, because of their strength, because of their mental status, because they really wanted to have a normal delivery, surprised even me and had a normal delivery. So I think the psychological aspect is important, and maybe if we pay attention to the antenatal, like in the antenatal clinic itself, if we have people or counselors who will help them, especially the first time mothers, who help them come to terms that this is a physiological thing. pregnancy is not a pathological, it's not a disease. It is something that is physiological. And if we make them understand that it is a natural process, perhaps they become more at ease. And the confidence of the doctor is also very important. Because if they see a confident doctor, a confident obstetrician handling them, then they become comfortable and they think that I will be able to do this. So I think that aspect that you brought out is also very important. Another thing I would like to say is that unnecessary cesareans now we are seeing a lot of repeat cesareans where we have the placenta accreta spectrum. So this again becomes a great problem. If you have PAS, you will definitely land up in a obstetric hemorrhage where you will land up in a cesarean hysterectomy. So bringing down the cesarean rate is very important. But another thing is that nowadays patient comes with cesarean on request. So when they come with that, then you are in a legal niche. So you either have to comply with them or you will be liable legally. But the only thing in this is that, again, counseling is very important. It's not that cesarean is a very easy thing. Cesarean can have anesthetic and especially surgical complications also. So when you open the abdomen, it's a Pandora box. You don't know what you will face inside. So in that way, if it comes to patients, perhaps we can bring down the cesarean rates. With this, I think if there's no other questions, we thank Dr. Ananya. Thank you very much for the participation.
Before we end, actually, I just want to raise something in the mind to our senior most of the seminar. If you can just give one or two words of advice regarding the two operations that we talked about.
I couldn't get your question.
We just want you to give some comments about the two operations and the discussion that you did.
Well, I will put down two factors. Considering I went through all three phases. When I started first, my operated career, my cesarean rate was somewhere below 7%. Then in my mid-career, it came down to just above 10%. But it was the fag end of my career, where it was mostly in private hospitals. Then, surprisingly, it climbed to almost 15%. As Dr. Shillong has said, the confidence of the obstetrician is very, very, very important. I did this 3 phases of my life. When I was young, I just was graduated. I was in the curriculum. I was a great gynecologist. There was nobody else. I was the CME. Okay? That confidence was in me. So I think it is a very important the confidence of the doctor. As time went by, because there were a lot of people who requested, I cannot tolerate you, I cannot deal with it, but there was confidence. You are going to have a delivery, and I see you will have a delivery. There was no fear, so confident. But most of the fact when the cesarean started rising, we did an introduction of the swimming part of the patients. Automatically, I found with age,
the confidence. What is going to happen? Suppose I stick to it. Suppose sometimes it's very busy. I'm going to teach you. You see, so all these factors play on your confidence. And I said, it is easy to be here. And that is how the cesarean rate goes up. So, to me, it is the main factor is the doctor's confidence. And all senior parents, you compare what we used to do in the 30s, what we used to do in the 50s, and now what we do in the 70s. Confidence, there is always confidence, lots of confidence as you is. So I think that is the main factor.
Thank you, sir, for sharing your thoughts. And with that, I think we end up the question now and we give them for the next session. Thank you all.
Ma'am, we have our second speaker, ma'am. Please be seated on the dais, ma'am. Yes, ma'am. So our second speaker is Dr. Sunal Kodawala, ma'am.
Let me introduce Dr. Sunal Kodawala. Ma'am is a consultant gynecologist and an artificial reproductive technique specialist in Ahmedabad in the Kodawala Women's Clinic in Ahmedabad. She is a trainer for surgery since 2006. She is a state coordinator for Conception Awareness FOGSI Family Welfare Committee 2010. She is also the program coordinator for school and college health education for FOGSI. She has 20+ papers in national and state conferences. She has 10+ journal articles and chapters published. She is the chairperson of the poster committee AICOG 2017, FOGSI and HRP Code 2019. A very warm welcome to you, ma'am.
Thank you, madam, for that kind introduction. And at the outset, let me thank the Shillong FOGSI Society and the Medical College, especially Dr. Ananya Das, for inviting me to this session. As Dr. Parul already said that he is happy to be here with the good weather and good city, but I would say I'm happy with the good people also over here. Everybody is so smiling and, you get a positive vibe over here in this city. So I'm really happy over here. Anyway, so my topic, as Dr. Ananya has already said, it is AUB. I'll be talking on AUB. So she has already talked about emotional quotient and all that, but I'll restrict myself to what we can do as a gynecologist. How do we deal with abnormal uterine bleeding and causing need for hysterectomy, and how to deal with it. So when we talk about abnormal uterine bleeding, it's by definition it is menstrual flow outside of normal in absence of pregnancy. It can be in volume, duration, regularity or frequency, but it also includes scanty periods. We'll discuss about heavy menstrual bleeding only. We all know that 33% of our gynec OPD cases are for AUB. 70% of all gynec consultants in peri and early menopause, they are almost always related to something related to their menstruation. And in reproductive age group, it is different. Here we know that extremes of reproductive life always have an abnormal uterine bleeding, maybe because of the anovulation is the main factor, but when we are talking about hysterectomy and all that, it is the 40+ years of age where hormones and neoplasia are more of a concern. Wave of change, because this was, everybody was describing the menopause, the menstrual changes in a different way. With this, FIGO decided to provide a supervision and global credibility for the new terminology. And in 2012, palm coin system was endorsed by SCOG. So we all know that the palm consists of all structural entities, that is polyp, adenomyosis, leiomyoma, malignancy and hyperplasia, whereas the coin contains coagulopathy, ovulatory dysfunction, endometrial, iatrogenic and not yet classified. Also, this acute uterine bleeding, which is unrelated to pregnancy, was also defined, which is sufficient in volume as to, in the opinion of the treating clinician, requires urgent or emergent intervention, and chronic, where AUB is present for most of the previous 6 months. What is very important is prevalence of increase with age of the heavy menstrual bleeding or women affected with AUB. When it is in reproductive age group, it is 17 or 18%. It goes to more than 24% in 36 to 40 years, and beyond 40 years, it goes even high. We all have already discussed the impact of AUB on quality of life, but what I really want to emphasize here is that over 60% of women diagnosed with heavy menstrual bleeding ended up having a hysterectomy within 5 years from the diagnosis. Those who continued with, even with part of our medical management and all that, they still continued having heavy menstrual bleeding and ended up with hysterectomy. We are supposed to deal with these cases, that how to prevent it. And about 1/3 of hysterectomies for heavy menstrual bleeding result in removal of anatomically normal uterus. When we say anatomically normal uterus, it is not most of the times it is not that palm, because these are all structural causes where we can find a reason why heavy menstrual bleeding is there. But the coin, it is the main, all coagulopathies, ovulatory dysfunctions, even endometrial disease. These are the causes which may not be evident when we do the investigations or the routine sonography. And here, these are the cases which end up with that. So when we say that we have the treatment options, can be medical or surgical, and we'll deal about it. But we have to be sure about what is the clinical condition, what is the stability, what is the severity of bleeding, what are the contraindications for medications, and desire for fertility, which might be there. So current treatment options we have, we'll discuss each one separately, but most of the times we have various medications which causes antifibrinolysis. Then we have hormones which are either estrogen and progesterone, and we have LNG, IUS as said, and another analogs. In surgical, we have endometrial ablation, which for some time back we used to do quite a lot, the balloons of the uterus, balloon treatment, and the endometrial ablation, which is now not in vogue, and hysterectomy is always there. In certain cases of fibroids, we have medical management and embolization as a management. So, first thing, when we talk about COIN, the C, menstrual excessive bleeding, most of these cases are diagnosed in their adolescent age group, but sometimes in women who are there, we are already diagnosed with coagulopathies, when they come to the menopausal age group, they have this heavy menstrual bleeding. So we have to diagnose them with their the exact cause of this, and if possible, we have to treat that. Ovulatory dysfunction, as I already said, both the extremes of life, but mainly anovulation even during perimenopausal age group. So what happens here is we see quite a few acute blood loss when we say. These are the these are the women who have, first episode of bleeding. They had 2 or 3 months of amenorrhea, which was around perimenopausal anovulation. And then they suddenly come with heavy menstrual bleeding with clots, which is not responding to the regular tranexamic acid and all that. And suddenly she asks for hysterectomy. So these are the cases where counseling is very important and we have to deal with it. AUBE, when we call to COE, so this is basically in ovulatory women also, there is a bleeding. The chronic endometriosis is one of the cause. Once we started doing hysteroscopy for our infertility patients also, we realized that endometriosis is an unknown factor which is not diagnosed inside with the routine sonography, and diagnosis by finding plasma cells, that is, an endometrial biopsy we may not do. But sometimes when we see the hysteroscopy picture, or we are just with the history, we think that this is an endometritis. If treating with empirical antibiotics, 2 weeks of 100 milligram doxycycline or even metronidazole does give good response. So we have to give it a trial when patient has those cases of kind of pelvic inflammatory disease, and then secondary heavy menstrual bleeding. AUBN, heavy malformation, as we said that cesarean rate is going up. We have seen that cesareans, one cesarean, two cesarean, the same scar. Everybody has faced that. Suddenly patient comes after a year with heavy bleeding. And in Doppler studies, you see that there is heavy malformation. These are the cases at the age of 40, 45, they come with heavy menstrual bleeding and end up with hysterectomy. But once it is diagnosed, we can treat these cases. Doppler is very important in this case. Another condition which we are seeing quite a lot these days is isthmosil, which is what patient after say their period is over, then after a week she keeps on bleeding, little bit of bleeding, and then she comes that madam I'm not, and then she has already taken a few courses of progesterone or estrogen and progesterone combinations, and it is not responding. When you do a transvaginal sonography, we can diagnose that isthmosil, which is the niche at the level of the cesarean scar, and with hysteroscopy we can easily diagnose this case, and if we can treat it at that time, we just have to shave off that the endometrium over there and remove that hole, I mean the reduction in the wall or at that level, and we can treat it. So that I just want to say that these are the causes which we might miss on our sonography findings, but we have to be, this history is very crucial in these cases. Okay, so when we see that apart from all these palm conditions, all this going, most of the cases of heavy menstrual bleeding are idiopathic. As it is said that most of the abnormal uterine bleeding, any variation, that is okay, but most frequent type and heavy menstrual bleeding is due to not because of any pathology which we can find. And here we have various treatment options which we would like to discuss. Hysterectomy is as such going to be the last one, but to begin with, we have to do, what we can do is that first is NSAIDs. We all have been using mefenamic acid right from the adolescent age group, but it addresses bleeding and pain both. The doses depends on whatever you decide, but results show similar values for mefenamic acid, diclofenac and naproxen. Tranexamic acid is the mainstay. Even right now the guidelines are suggesting tranexamic as first line for even treatment of PPH and for all kinds of bleeding disorders. So here it has a slightly better effect on bleeding. So I think all those cases where we find that the bleeding is not, I mean it is only heavy menstrual bleeding at the time of periods, we have to give a trial of tranexamic acid, either 500 milligram 3 times a day, or we can go up to 1 gram QID. And if patient is responsive, here again counseling, we have to tell the patient that taking tablets every month is okay, because most of our patients feel that it is, like it's not good to take these tablets every month. So, but if we can avoid any surgical intervention because of that, that should be okay. Combined oral contraceptives are going to be there for each and every case of menstrual irregularities forever. Whatever we say, whether estrogen is good or bad, but I think that it has its own value. Combination of both estrogen and progesterone administered orally. Possible dosing regimes can be either 21/7, 24/7, or these days the low dose which is coming with Denogest with 28, 26/2. And all those medicines can be helpful in preventing that. When we are talking about, here again we have to exclude all palm causes, we have to exclude all coin causes, and then we can give a trial of that. We have to be sure about there are no contraindication for estrogen in these cases. Okay, that brings us to the most important hormone, which is progesterone, which is the mainstay, I would say, for all cases of heavy menstrual bleeding which are in the perimenopausal age group. We have a plethora of this thing, either injectable, high-dose oral progesterone, gonadotropin-releasing hormones. It's not progesterone, but that can be also a hormonal thing. So injectable progesterone, let me just say that when we are using it for a for a short while, for a short period, it's okay. Because dipomedroxyprogesterone, it can have very good effect on reducing the blood loss. So the patient gets confidence that, okay, medical management does work. But in this age group, we are worried about the osteoporosis and the bone loss. So we should not continue it for more than a year or so when we are waiting. Especially see around that age group, when we know that now menopause is due, we can give it at times or we are buying time, her hemoglobin is low and we are waiting for hemoglobin to improve. Progesterone implants are not recommended for this, only to prevent, as a contraception only it is used. But what is the main hormone which we use is medroxyprogesterone and norethistone acetate. And I think in our practice, we all have been using norethistone acetate quite a lot. Here, only thing I want to say that though we can use both 10 milligram, 15 milligram from day 15 to 25, but usually when we are talking about these patients, I think day 5 to 25 would really work well. Why? See, because quite often it so happens that patient is on hormones, progesterone, and she doesn't respond and ends up with a hysterectomy. So here we have to take care that if we want to give progesterone to improve her blood loss, we have to give it from day 5 to 25. Day 15 to 25 has a role when, as I said previously, that patient has 2 to 3 months amenorrhea and then she has heavy bleeding because of anovulation over here. So here if we give a withdrawal bleed before her endometrium is too large or before the unopposed estrogen is too much, so then it doesn't respond. So in those cases, if we give a progesterone and get a withdrawal which is helpful to her. How does it work? It suppresses ovulation and prevent endometrial proliferation. And how well it works? Because it's seen that short course oral progesterone luteal phase only have no effect on menstrual blood loss. But in this RCT reported an 83% reduction in menstrual blood loss with long course use of oral progestagens. So we have to, because like just saying that hysterectomy is not indicated, I mean we should avoid hysterectomy, but patient is suffering. Patient is suffering from her bleeding, and we have to give her blood, IV irons and all that, because she is anemic. She has so many problems with anemia. So our aim is to prevent heavy bleeding for each and every cycle. Even if once we say that no, uterus is normal, your ovaries are normal, so no need to worry about it. It cannot be done. We have to give them something. So that brings us to the which is very, I'm very happy with this molecule is LNG-IUS for heavy menstrual bleeding. The NICE guidelines suggest that when there is no identified pathology, even fibro is less than 3 centimeters, not causing distortion of uterine cavity, or suspected or diagnosed adenomyosis, which is causing heavy menstrual bleeding, LNG-IUS is the treatment of choice. FOGSI GCPR summary of recommendations for abnormal uterine bleeding recommends it as a first line. But let me see like in AUBC, we will do consult a hematologist, treat the coagulopathy, and then we can, right now I have a patient who is 55 years, I have done her first cesarean. She has factor 9 deficiency. In second cesarean, she went somewhere else and she had many problems. I've been continuously giving her hormones for up to age of 40. Then I put her LNG-IUS. Right now she is in third LNG-IUS. She is now almost 51, 52. But coagulopathies also, this gives very good results. We have to counsel these patients, as we all know that the first 6 months they have to bear with those irregular spotting and all that, but later on it is very effective. Here let me tell you that in AUBO, sometimes when we give LNG-IUS, these patients have ovarian cysts along with that. So at times the endometrium is thin, but when she comes up for follow-up, there are ovarian cysts. But these ovarian cysts we can again treat with either oral progestrogens or estrogen progesterone, or for a short course. And here, for first 6 months also, I have seen that when patient has irregular, they come you remove LNG and go for a hysterectomy. So here counseling is very important. At times we have to give estrogen, because these are the patients who have this thin endometrium, but still they are not responding to LNG. You give one cycle of estrogen plus progesterone and the bleeding stops for a while, and then she is happy with it. And then I think we can deal with it for day 5 to 25 oral progesterones along with LNG-IUS and give a good results. And within 6 months, the LNG is working properly, and then we do not have any problem. In AUBE, when the estrogen is contraindicated, again LNG-IUS is the drug of choice. In all iatrogenic causes also, I think LNG-IUS, and in, as I said, not specified the causes also, LNG-IUS does. It has a two-pronged approach. It goes medical therapy for idiopathic HMB and also method of birth control. In around age of group of 40, when they come with heavy bleeding, we can deal with both the things simultaneously, and comparable efficiency without need for an analgesic or anesthesia, and cost effective. That is again a major factor. Let me tell you that when we are giving oral progestrogens for a long time, these patients, they do not want to take it. I mean, they'll skip a few cycles in between because they feel that it is very expensive. But once you give them a single time expense, that okay, you put this and then for 5 years you are going to be okay, the patient compliance is much better. This study is a very pilot study was there, and there the reduction in menstrual blood loss with LNG-IUS was almost 87%, whereas with COCs it was up to 76%, and treatment failure again was much less with LNG-IUS. So I think that it's more effective therapy for with lower failure rate, blood loss, and improvement in overall quality of life of women. So when we are talking about, this is just concise way we can say that when we are talking about AUB palm, we have to, instead of like there are multiple fibroids, okay, that doesn't mean that we have to directly go for hysterectomy. We have certain guidelines that, if it is less than 3 centimeter, cavity is good. We may not go for myomectomy also. We can avoid surgery and we can give her medical management. Or in polyps are there. They are not going to respond to anything. Instead of going for hysterectomy, we just do a hysteroscopic polypectomy and that's it. Multiple polyps, again, what we do is we do polypectomy, we remove the polyps, we do the hystopatho, everything is okay. Then as an OPD procedure, we can just insert an LNG-IUS and that's it. With AUBL, again, surgery whenever there is a resection of either fibroids or polyps, and then we can insert this. Long-term management, we will say that LNG-IUS is must. In short term, we can give either oral progestogens, which does. AUBM we'll discuss later on. In COIN, we can say the non-hormonal treatment, tranexamic acid is going to be the mainstay when the cycles are regular. Only during cycles, if they have heavy periods, we can deal with just medically. Again, an ovulatory we already discussed, but here there is a role for oral progestrogens also, because this anovulation may not last for 10 to 15 years. This oral progesterone may be good enough. I mean, we can give it to tide away the time till the anovulation is there. Okay, let me discuss one case. 47-year-old woman with heavy menstrual bleeding since 9 months, 5 to 6 pads, no associated pain, history of metromenorrhagia, no history of dyspareunia, G3P2L2, TL at age of 31, uterus normal size, non-tender, adnexes are non-tender, there was no mass. But in ultrasonography, we found a polypoid endometrium. Diagnostic hysteroscopy done. Here, why I put this case is because, we see so many patients where the thick endometrium, polypoid endometrium, it's just written in the transvaginal sonography. The Doppler suggests that there is a vascularity. But when just going for routine diagnostic DNC, we might miss those polyps at times, and that is really like, second, third consultation they come to us that somebody has done DNC and the report is just hyperplasia, or it is not even hyperplasia, proliferative phase, and still she is bleeding, and again the sonography is showing hyperplastic endometrium. So I think when we are dealing with hyperplastic endometrium, just even office hysteroscope, we just put it in, and if there is a polyp, we can remove that polyp. It would be diagnostic cum therapeutic, and then we send the material for the histopatho. So I think this won't work, this video in this case, but let me tell you, when we are doing biopsy for endometrial, or we are dealing a case with endometrial hyperplasia, we have to be very cautious about ruling out malignancy, because patient is worried about mainly that, even we are worried about that. So here I would suggest that hysteroscopy, yes, there is a hysteroscopy directed biopsy also we can do, but along with that, getting that suspected area, I prefer a vacuum suction. Instead of directly going for curettage, we do a vacuum suction, because these are the friable cells. These are the cells which have disorganized vasculature, and these are the cells, you can see that vasculature, and these are the cells where there is this kind of punctate calcifications are there. This is a classic sign. So first we do a vacuum aspiration. So these are the cells which are really malignant or who have that tendency, they'll be sucked out. In DNC, we might miss those cells. So I would suggest that we do even if you do not have a hysteroscope, whenever we do a DNC for a hyperplastic endometrium, we have to suck out the first. We have those vacuum aspirators. First do that and then do thorough curettage as a therapeutic treatment. And we send that for histopathology examination. So when we talk about cancer, a little bit, I said that in palm, the M word for malignancy, incidence of endometrial hyperplasia is estimated to be thrice the number of cases of endometrial cancer. And if left untreated, it can lead to cancer. So we have to treat that. But we do not, every hyperplasia need not be a cancer. Endometrial hyperplasia is 3 times more common. So histological classification, once we have done the biopsy, is simple hyperplasia without atypia, simple atypical hyperplasia, complex hyperplasia without atypia, and complex atypical hyperplasia. So how do we deal with it? So as I said that endometrial biopsy and hyperplasia is confined to endometrial polyp, then we have to do polypectomy, should be performed for the biopsy, and then we send it. So the main guideline is to prevent the development and progression of endometrial malignancy in these cases when we find that there is no atypia. If there is endometrial hyperplasia without atypia, we have to prevent the development and progression of endometrial malignancy, to rule out the presence of a coexisting endometrial malignancy, and to offer a treatment plan that best suits the treatment of patient. And here progesterone is the mainstay because that is the protective thing, and estrogen is implicated. So LNG-IUS delivered locally has all these things. Simple or complex hyperplasia in absence of cytological atypia can be treated conservatively. This is the main point. Even if there is just cystic hyperplasia is the report from the histopatho. So we just do not go for hysterectomy, but we see that if there is no atypia, this can be treated with progesterone. And progesterone therapy is appropriate for most women with endometrial hyperplasia without atypia and may result in its complete disappearance. So first line treatment, continuous progesterone can be used, methotrexate 10 to 20 milligram or norethistone for women who decline the use of LNG-IUS, though my first line would be LNG-IUS. But here again, cyclical progesterone should not be used, but we have to use continuous progesterone when we are talking about atypia. Or when we are talking about hyperplasia. So either oral progesterone in continuous use or at least day 5 to 25 and give her a withdrawal, not 15 to 25, and then we use without a patient should be informed here, as we said that it is to be an informed consent, because that doctor said that patient wants hysterectomy or they are asking for it. There is something called demand hysterectomy. In fact, in Dr. Ananya's slide, it was there that the higher level in our Gujarat, most of the patients come from Rajasthan. They are laborers, and at the age of 30 and 35, they all demand hysterectomy because they say that then only we can work properly. Because we have finished our obstetric career, and because heavy bleeding can create problems because we have to do manual labor. This is a very wrong concept from them, but actually we have to counsel them that whenever there is even hyperplasia, risk of progression to endometrial cancer is less than 5% over 20 years. Majority of cases will have spontaneous regression. Addition of progesterone into treatment plan produces a higher disease regression and then observation alone. So we have to give them progesterone. Identifying and addressing modifiable risk factors such as obesity and use of exogenous hormones like HRT and all that. Consider observation with follow-up endometrial biopsies. Here because I've written tamoxifen, these days now it is said that all progesterones are implicated. So whenever patient has already had breast cancer and now she has been treated with it, still progesterone is contraindicated. Recent guidelines suggest that even LNG-IUS has you can use it for a short while only. You cannot use it for a long while because progesterone is no longer given on breast cancer patients. So endometrial hyperplasia without atypia, hysterectomy need not be considered as a first-line treatment because remission symptomatically and also histologically can be obtained through progesterone therapy alone. This is what I want to really highlight. Hysterectomy is only indicated in women not wanting to preserve fertility along with progression to atypical hyperplasia, no histological regression despite a year of treatment, relapse after completion of progesterone therapy, persistence of bleeding symptoms, refusal to undergo endometrial surveillance, because these are like, if there is a even hyperplasia is there, then we have to do regular at least transvaginal sonography, and we can do just biopsy with a pipelle after a year, after 6 months, when there is a high endometrial thickness is more. So, but these patients have to comply with endometrial surveillance and with medical treatment. If that is not there, then hysterectomy is the answer. With atypia, there people have seen that even with atypia, patients want to preserve their uterus. So in these cases, consider total hysterectomy as a risk of underlying malignancy or progression to cancer is higher. Ablation is not recommended, but there is a review and routine EB should be performed every 3 months according to women's clinical condition until 2 consecutive negative biopsies. They need not undergo his anesthesia. We can just do it with pipelle, but routine EB has to be done when there is atypia, positive atypia in the previous endometrial biopsy. Then we have to do every 3 months, and 2 consecutive negative biopsies are obtained. Then we can treat these patients as only follow-up with ultrasound, transvaginal ultrasound. If a woman wishes to preserve fertility or is unsuitable for surgery after hysterectomy, once fertility is no longer, offer fertility hysterectomy when fertility is no longer required. But even in those cases where they do not want hysterectomy, we can try this and have a long-term follow-up with 6 to 12 monthly endometrial biopsy until at the end, if that continues to keep on coming positive, then we have to ask them to go for hysterectomy. So in conclusion, I'll say that heavy menstrual bleeding is the most common indication for hysterectomy in India. The usual medical treatment for women with AUB includes tranexamic acid, mefenamic acid, combined estrogen, progesterone, or progesterone alone. The biggest worry among such patients is possibility of malignancy. Relative excess of estrogen continues. We have to see that we know that relative excess of estrogen contributes to endometrial hyperplasia and cancer. So anti-estrogen medication, which is progesterone, is the mainstay. It reduces this, and oral progesterone and LNG-IUS have local anti-estrogenic and direct anti-proliferative effects on endometrium. Careful diagnosis, judicious medical therapy, and counseling can reduce the need for hysterectomy and save the uterus, which is our main goal. Thank you for patient hearing.
Thank you so much, Madam, for that beautiful presentation. I think before we go through on the next session, we would like to give, I think, 2-3 questions or comments to the audience. Yes, Dr.
Ma'am, it was really a very wonderful presentation. I'd like to know one thing, like suppose just recently there was a patient of mine who was having severe adenomyosis. She was actually in pain. I mean, it is like a chronic pelvic pain. And with endometriotic cyst, which is bilateral. She's a post-ovarian patient around 35 years of age. The last childbirth was around 8 to 10 years back. So,
I had similar patients, and what I have done is I give them GnRH agonists, then add back estrogen for a while to prevent this. So overall her heavy menstrual bleeding is comparatively controlled, and then I put an LNG. We know that LNG doesn't reduce the pain element. So here we have to give them sometimes first 3 to 4 months Dinogest along with it. I do give it Dinogest tablets along with it. It takes care of the pain, and because there is complete anovulation, and we all know that even in chocolate cyst and adenomyosis, the pain element goes down with that. But along with that, I put LNG-IUS. So by the time 6 months the LNG is effective, the bleeding stops. Then she has to take the mefenamic acid and all that for her pain.
And what about chocolate cyst?
Chocolate cyst, see. As an ART specialist, I would say that up to 3 centimeter chocolates we are not doing anything. If it is causing pain.
8-10 centimeters.
No, 8-10 centimeters, there is no question. Even I thought it is a small one. 8-10 centimeters, there is no question. Surgery is the treatment.
Yes.
Surgery is the treatment. I mean, we are talking about idiopathic heavy menstrual bleeding only. If there is a cause, there is a chocolate cyst of this large size, if she has not finished her fertility, I would suggest surgery.
Yes.
I would suggest complete cystectomy and then whatever we are giving, either Denogest or LNG or whatever for the time being, and then we can, treat her fertility if she wants it. But otherwise, even for infertile patients, when obstetric career is not over, I would suggest surgery is the answer. We cannot prevent, cannot avoid surgery in this
So
case.
what I did was, since she was 35 years old, and she was separated also, she was not with her husband, with just one kid. So what I did is, I removed her chocolate cyst, of course it was big enough. And then in the same sitting, I had put in that OP only, I had put NEIGRIHMS also. Then the pain was not really much, I had to add bandages in her next visit. And finally, that also didn't help. So after 1 year of all those procedures, I had to finally take her up for hysterectomy.
I have done in my career, which I really, I'm really unhappy about it, but I have done hysterectomy in a lady, infertile lady, with severe endometriosis. We had done 2 laparoscopic surgeries to remove her chocolate cyst, for adenomyosis, everything. She was in severe pain and she said that, no madam, whatever you do, I've already adopted a girl, I don't want this uterus anymore, this is affecting my family life. See, endometriosis is such an enigma, you cannot just prevent that. Everybody knows, whoever has dealt with grade 3, grade 4 endometriosis, that even that simple rectovaginal nodule, it can cause divorce. That kind of thing, patient is so bad. So we have to go for surgery. We would always try to do a conservative surgery, but if whenever required, we have to do for the advanced surgery also. Yes. Thank you.
That is a necessary.
Yes, sir.
I have one question also.
Madam, I would like to know what is your take on post-menopausal bleeding? You see,
Yes, sir.
in our days, that is I'm talking about.
See, sir, recent guidelines.
60 days, indication for hysterectomy was post-menopausal bleeding. But since the introduction of your pharmacohen classification, I don't hear anybody talking about post-menopausal bleeding.
Sir, we have done a big study. We have prepared a paper, a big study on postmenopausal bleeding and hysteroscopic diagnosis on that. See, basically, the guidelines suggest that you have to do a transvaginal sonography, and these days, if endometrial thickness is more than 4 mm, otherwise, in a routine sonography, even up to 5 mm, it's okay. But if it is postmenopausal bleeding, then endometrial thickness more than 4 mm, you have to take a biopsy. We would suggest hysteroscopy directed biopsy, and then according to the histopatho reports, we have to deal with it.
If everything is normal, your endometrial thickness is less than 4 mm, and endometrial biopsy is normal.
Your per speculum examination is normal also, because this postmenopausal women, quite often they come with just spotting and it is atrophic vaginitis which is causing this bleeding. I have seen quite a few patients and they have undergone so many transvaginal sonographies to find out the cause, and actually it was the atrophic vaginitis which was causing bleeding. But otherwise, I think we have to get the sonography to see the ovaries also along with that. But rest of the things, I don't think you need hysterectomy in these cases.
No, but she comes with repeated postmenopausal bleeding, and every time you do a endometrial curettage.
No, we don't do curettage. We do transvaginal sonography and one curettage to diagnose it. If endometrial thickness is less than 4 mm, we just do one hysteroscopy directed biopsy.
Okay,
That's it.
Normal.
That is normal.
After 6 months, she comes back with repeat bleeding. What are you going to do?
You want to say something? Please.
See, basically, this kind of cases will be very, very rare. Clean endometrial and repeated, very rarely atrophic endometrial can cause bleeding. We can just counsel the patient that it is not a very harmful thing, but if she still insists on a but cancer really we can do that. Now, clarity is like this. First episode of postmenopausal bleeding more than 4 mm abdomen, you should do a hysterectomy. And I identifiers, anything which is abnormal, we can know. And if it is, everything is normal, then that you. If it is less than 4 mm, second episode, then again you have to check for 1 to 2% of even the end of it. But if these are not there, like there is no hyperplasia or no malignancy, then repeated bleeding are not the cause of cancer. If this still patient insists that I am worried, remove the uterus or the esophagus, but it's not a medical indication.
Because in my experience, I have come across a number of cases, and after that, I started advocating hysterectomy. Because you see, a patient has come first time. I told her pregnancy, I told her everything is okay. She comes back the second time. I do the registration, I tell her everything is okay, you need to worry. Now the third time she comes after 5 years with a dependent leave, and this time I detect it is malignant. Now she told me, I feel like I should have removed the uterus, and I've come across a number of cases like this. And
It is very rare, right?
Till now, I have changed. I always advocate that if there is a recurrent, in the first instance, no. Second instance, maybe no. After that,
Thank you for that input from your experience, because we are.
utilize is normal, and the third time she comes after 5 years, and there is malignancy. I just was dumbfounded, I couldn't do that.
I have seen spottings with cervical erosion and all that. That is quite common. They come with bleeding. But sir, as you said, if it is in your experience, you are seeing more patients like this, that is different. We hardly see any patient who is coming after second time we do the biopsy and all that. Otherwise, I think hysterectomy. See, our basic idea is to treat our patients and to avoid all kinds of complications. So hysterectomy, as and when required, is there is nothing like we cannot do hysterectomy. Hysterectomy is going to be a mainstay of treatment for everyone.
Yes,
that is not.
My advice to the present younger generation, please keep this in mind. Don't take it lightly.
Yes, yes.
Everything is normal. Nothing to worry.
Yes.
You have to keep this in mind.
So that is that you have to do that follow-up is must.
You will come back in a lecture.
Yes. Thank you.
Thank you,
Thank
sir.
you. Thank you.
Ma'am, just ask one more comment, or there is a code ruling that 40 years is a cut-off age where we have to think for hysterectomy.
Sorry, about the court ruling. See, recently there is, Parul would know that there is this thing that you have to take permission from the government. Right?
We are supposed to report.
Court is not court, but
some governments, not all states, but some governments have insisted that anything below 40 is required as to check by the head
of the medical college, that's what it is. Like, government medical college.
We have to report it to the DHF.
I think they won't include obstetric hysterectomy. No, but Gujarat also, it has started now in certain colleges that you have to take you have to inform them that because of this reason. But there is no court order right now. No. Okay. Yes.
For this hypertension, patient coming with hypertension, ABE or then you will set a patient as a assumption and then hysteroscopy suctioning. We need suctioning with carbon.
You see, actually, I have got a suction cannula from, I'm getting it, I do not remember the name from US, but that is, you can use Carmen cannula also if there, because but then you have to dilate the cervix.
Yes.
So we use a smaller one, which is like a pipelle, but it has that syringe and everything, so you can get a proper suction with that. In case of multiple polyps, we use the cannula which is similar to Carmen cannula. Because there you can take out the big chunks of those polyps. Even when we do polypectomy, hysteroscopic polypectomy, then also we apply those suction cannulas because to take out all the material from the uterine cavity, it becomes easier. But I think you can use that, but then you have to dilate the cervix. That is the problem.
So I'm not sure whether people is as good as doing.
No, but see, I am saying this is for diagnosis. Then we do a routine curettage. We send that also for the histopatho. What I am saying is that which people which you get with negative suction, these are the cells which are likely to be if at all there is a malignancy or aplasia, these cells are going to come out with suction immediately. The normal cells won't come out that easily.
So people is as sensitive as your hysteroscopy.
No, hysteroscopy directed biopsy is first. No, hysteroscopy. See, I say.
Focal disease. If it is a generalized cancer inside the inauguration, then a focal disease. Yes, but I can you are upgraded on the next side, this is on the next side. 50% is missing out. With vacuum rate, it increases to 80 to 85%. And with high directed biopsy, they have cancers which is 97 to 98%. Nothing is 100%.
See, I am talking about a place where you do not have a hysteroscope and you are doing it, then I think instead of directly going for DNC, we must do negative suction evacuation and then do DNC.
Yes. And one more thing, when we are talking about responsibility,
Sorry?
When we are talking about responsibility,
yes.
So when we go to the we are cutting the lower edge to release the erection. So after doing that, do you think that the patient is more, if she gets pregnant again, is she more likely to get scarring? Is she at a higher risk? Is she equivalent to the other population?
I think it has more chances of this, yes, because you are weakening the scar. But these are the cases which are perimenopausal age group coming with this. So most of the times, but like suppose say there is a scar pregnancy, what has happened? So there we put in a hysteroscope also, a laparoscope also, and see the scar and strengthen it if required. That is for scar endometriosis, scar ectopic I am talking about. There also again the scar is weakened. Right.
In this most of the different cancers, the thickness of biometric should be at least 1.5.
1.5, yes.
And only otherwise you have to refresh test.
Yes.
If pregnancy is required. Here the discussion on AUV. So if these patients typically have NSIS and NS40 for a long period of time because the blood is from them. We have hospitalization on the other side. So if you are widening the lower flange, you are cutting. So the blood will not be retained. That is only for the.
So because these are the cases where progesterone also doesn't work. These are the cases where progesterone doesn't work, so we have to go for hysteroscopic sorcerer.
And regarding people is excellent. Only thing is you can get RD from 0.5 to 1 millimeter of tissue. So endocellular realize there's cellular thickness is flexible and you can attach a cylinder with a lock. So you just vacuum it out, lock it, so material can serve.
And endosampler comes in both sizes, so we can use for perimenopause just thick endometrium different, and for multiple polyps we can use. I was not getting the name endosampler. Okay.
Main purpose is OPD procedure. This has to be outpatient. So for polyps and all, it has to be under anesthesia. So inhale or inhale, but both have 3 millimeter things. So if it goes inside, you have a damage.
Thank you. Thank you.
So with this, we close the session. Thank you very much.
Thank you so much, ma'am. Now I would request Dr. Ananya ma'am to felicitate our chairperson, Dr. Uterus Shillong ma'am, and our speaker, Dr. Sonal Kodawala. Now heading towards the much awaited session, that is oration by none other than Dr. Parul Kodawala sir. Though he doesn't need any introduction, he is the chairman of Indian College of Obstetrician and Gynecologists. Now I would like to request the chairperson for the next session, Dr. Shamdhar sir, to please come to the dais, sir. Dr. Shamdhar sir is the former Joint Director of Health of Meghalaya, ex-Medical Superintendent, Ganesh Das Hospital, Founder Fellow ICOG 1986, Founder Fellow ICMCH 1993. He was the Founder President of Shillong Society Society 1998. He has organized 12th NEIGRIHMS Shillong 2001 and have received Lifetime Achievement Award from Shillong Society. Now I would like to hand over the dais to Sir to introduce our speaker for the next session.
Thank you very much for your kind introduction. And also, I would like to thank Dr. Professor Das for inviting me to chair this session. This evening, we are very privileged and honored to have such a great person, Dr. Parul Kodawala, being with us in the CME. We are fortunate that the chairperson of ICOG is with us, and I'm sure after the presentation of this oration, we will all be very, very much benefited. With these few words, I have the privilege, honor to invite Dr. Parul to please come and deliver his oration. Thank you.
Hello. Well, sir, it is indeed my privilege to see you as chairperson. You are a founder fellow of ICOG, of which I represent today. I'll be moving on to the topic directly. I have two parts. One is difficulties faced at cesarean section. Over last maybe about 30 years of working in medical college, and also attending many SOS calls from colleagues in private, I have gathered a lot of situations where I had to handle those. I am sure that all of you have done more cesareans than what I have, and all of you might have at some point of time found something difficult. And rather than, I would say, making it a lecture, I would think that if it is a dialogue, it is better. And I would also solicit all your experiences also at the end of what I share with you today. How do I change the slide? Okay. Well, it is so very interesting that in last 2 months, last 6 months, I have had opportunity of presenting the same subject at various places all over India. What is your number one difficulty while doing a cesarean section? Please think about this, and at the end of this, we will discuss those. What we will discuss today is abdominal wall, problem facing while we are dealing with it, lower segment, baby delivery, closure of uterus, and previous cesarean section. In abdominal wall, our intentions are quick and easy access to the uterus and delivery, good timely healing of the scar, no long-term issues like hernia, keloids, or paresthesia, and if we required at second cesarean, what would be the problem of abdominal wall. So, when we look at the entry difficulties, we have, if the scars there are over abdomen, I'm sorry because of my height. So, previous cesarean section or any other scar, but mainly it is the previous cesarean. The type of incision selected, additions inside or over the abdominal wall, and morbid obesity. Now, when we look at the scars over abdomen, if there is a previous vertical scar, it becomes a difficult decision to make, because nowadays, by and large, we have moved to transverse scar. Some of us are persisting with Pfannenstiel, and some of us are doing the Cohen type of incision. So, medically speaking, vertical scar is no, because it has a high rate of later on the hernia formation. The reason is very simple. It is a vertical scar, and patients, when they bend forward, the muscles go apart and the pressure is on the scar. It may cut through also or weaken the scar. In a transverse incision, whenever patient bends, it relaxes the scar, so healing is better. Nowhere patient would go backwards, and that is why a transverse scar is better. Now, I discuss with my patient, what would you want? Do you want a cross on your tummy, or medically speaking, go through the same scar, which is cosmetic, but this is medically better. Till date, only one patient asked me that, doctor, go through the same scar. All the rest have said, whatever is medically better, please do that. Then, second issue comes Pfannenstiel versus Cohen incision. The Pfannenstiel scar was hairline scar, and many times the hair follicles would grow in the scar. Post-operatively it was painful. But more than that, second main issue was that when you go inside, what happens, our rectus muscles are fixed over the pubic crest. You put your retractor. So this muscle will not flatten out. So you are constantly pulling onto the muscle. The lateral edges of your retractor are constantly abrading the muscle. There will be post-operative pain and numbness over those muscles. Secondly, the space will be less. So many times people used to tell us that the upper part of uterus is not seen in Pfannenstiel because you are retracting, but that V is formed. V can be widened, but it cannot be horizontal. Whereas when you go, and third thing was that when you go for a second cesarean following pregnancy, the rectus sheath is adherent to the muscle, and we had to dissect the rectus muscle from the sheath. When you go higher up, this is the coax incision, the black one. Here what happens, the rectus sheath is not adherent to the muscle. So you are not dissecting the muscle from the sheath. So there is no adhesion formation for the subsequent cesarean. You will be always easily separate the muscle. Second thing is this formation of V is not so very important because the muscles are open here. You do not need to pull so much. And those things have led to preference for slightly higher transverse cut. Now I am putting forth a new thought. Supra-umbilical incision. I have had to do it a couple of times. You can see now, these are situations. This girl had ectopia-FOGSI at her birth. She had 5 operations. She had suturing over the pubic symphysis. The bladder was put inside. I was not interested in going through that. And she said, I want only one child. How she became pregnant was also very curious because just one finger pill with great difficulty I could make. So we went and it was so easy, simple, patient was very happy. Unfortunately, after 5 years she has come back. She wants another child now. Anyway, so it was a funded delivery. This is another case. Now I discuss with you the obesity part. Here also some repair on the bladder trauma was done. So anything in lower segment is problematic. Don't make it a point always as an ego issue that I will do only a lower segment cesarean or a transverse cut. But vertical cut, whenever possible, you should avoid. In our fraternity, there is nothing 100% and nothing 0%. So someday I may have to make a vertical cut. It is not a big issue. We have to do it if necessary. Similarly, high incisions, higher incision on uterus, also in selected patients who may require it. That brings us to the big problem of obesity. Of late, last 10 years, we have seen gradual increase of pregnancies with high patient weight. The paniculus, depth of incision, angle of delivery, and I have mentioned the supra-infra-umbilical transverse and epigastric approach. See, we have a tendency, for years we used to do this. We would lift up the paniculus, pull it upwards, and put the cut below. Now, post-operatively, this pannus will overlap this. There will be irritation, moisture there, and gaping infection dosage usually. Instead of that, what I propose is pull it down. Pull it down and put your cut here. This will be closer to the umbilicus. Doesn't matter, but medically speaking, it will be better. And see, this is a case in point. You can see much higher incision over the abdomen. And there are data also to support this. Caesarean section in morbidly obese women, supra or subumbilical transverse incision. Vertical skin incision, everyone says, should never be done. This high, now just imagine this paniculus overlying this. It would be a big problem. So delivery by caesarean section in super obese women, think beyond penicillin. So elective CS often performed because of suspected macrosomia may be best in many women in this category. So this is one thought which I am putting across. I have done it with successful. Then we reach the lower segment. Lower segment, our intentions are quick delivery, less blood loss, less extension of incision, avoiding trauma to the bladder, good approximation for future delivery, and if there is a placenta previa anterior, what to do. So if there are additions, tumors in lower segment, a fibroid, torsion of uterus, anterior placenta previa, transverse line, polio or pelvic trauma issues are there. But in these two, adhesions If they are extensive, you may think of going on the upper part. If you can decide those, if you are confident, go ahead and go for lower segment. Tumor, if it is there on the cervix, I have done a cut along the edge of the fibroid on the upper side. And after delivery of the baby, I take a decision whether to remove the fibroid. But along the edge of the fibroid, it can be slightly oblique also, doesn't matter. Torsion of uterus. When you open the abdomen and if you see the ovary or fallopian tube in front of you, think of torsion. Identify both the round ligaments and then correct that. Then delivery is not a problem. The only thing is if you cut across the broad ligament without correcting this, you are going to be in big trouble. So whenever you see ovary or fallopian tube in front of you, think of torsion, correct it. Transverse line, especially what we have seen is that the lower segment is ill-formed and we have to deliver the baby through that. So instead of horizontal cut, we make a U-shaped cut. Some people often do an inverted T. Now inverted T I personally feel is not appropriate, it is as good as a vertical cut. Because all the problems of a vertical cut are there in T-shape also. So either J shape where your cut you extend laterally higher, or a U shape of cut, it is a flat wall kind of a thing, deliver the baby and it falls back. This has lesser subsequent issues. Back inferior is very easy, back superior is very easy, the limbs are down below. Just catch hold of the foot and put it out. But back inferior is a problem. Here, I would suggest that on the table, identify the head where it is, try and push the head up. That way, buttocks will be slightly lower. And without waiting, pass your hand towards the buttocks side. Because once you allow the diaphragm to drain, it will be difficult to turn up the baby, reach the foot. Immediately pass your hand, catch hold of the foot. So follow the foot principle is the best. So curve of spine upwards is very easy, but curve of spine downward would be. External modality version if you can make on table, that would be the best. As I said, keep on pushing the head up. Placenta previa interior. Nowadays, with ultrasound, we are much better off. I would suggest that look at the cervix. If your placenta is covering the cervix, that means most of the placenta is in the lower part. In that case, after cutting, go up, pass your hand between placenta and uterus up, rupture the membrane, again catch hold of the foot. Here, the head delivery will be difficult. This is a floating head and placenta will also hamper the exit. Catch hold of the foot and pull it down. But if your placenta is not covering the cervix, it is away from the cervix, edge of the placenta. That means more part is higher. In this case, pass your hand between uterus and placenta downward. Rupture the membrane and deliver. Here it will be difficult to catch hold of the foot because it will be much higher. But that is perhaps the only way you can safely deliver. You may use a vacuum or forceps in this situation. Delivery of the baby. This has been a very contentious issue of late. High floating head, deeply engaged head. Twins is not a big issue, but we'll discuss transverse line, follow the foot, and preterm fetus. Now, floating head can be because of a very large head, or a preterm fetus, or there is placenta previa. What we do is, not in placenta previa, but in other things, allow the drainage of liquor so that the uterus contracts, pushes the baby a little bit down. You can start pre-delivery oxytocin. That will also enhance the contraction, push the baby down. Use either forceps or vacuum. By and large, I am doing vacuum. Previously, I was a fan of forceps. Or else, follow the foot principle. Many of you might have heard of or operated Patwardhan's method of delivery. Unfortunately, he is not given the due sort of respect for this, and British people always talk of reverse reconstruction. Basically, the idea is that of Dr. Bhagavad. For preterm, now Dr. Piley from Kerala has developed beautiful small faucets. Now, can you see this is the outlet faucet, the release faucet, and these are smaller ones for small heads. And one more anatomical variation, faucet design variation is, look at this. This is for vaginal delivery. Here the pelvis is keeping these two blades in position when you are pulling down. But when you are doing it at cesarean, there is no external pressure of the blade, and your faucet will come off, slip off, and hence you need blades which go very close to each other. This will give a stronger grip. So both these have a stronger grip, they are tiny and thin. Same process, you can see the distance here. This is for vaginal birth, these are for the cesarean. Vacuum at cesarean, I have always kept a vacuum cup on my table ready for use. Floating head, flexion point internal diameter 5 cm, traction force minimal, increase the size of scar. Now these, I do not know what vacuum are you people using, but this was very popular, the kiwi cup. But here the design was, one is this is a very thick cup, and second the pull is perpendicular. In vaginal delivery this is correct because this is in the line of the fetal head. In cesarean, two issues are there. We need a thinner cup, and secondly the line of pull is at an angle. The baby is moving downwards, you want it upward. And so you can see the design is that you pull anteriorly. I personally use this cup. Mitivac is the company. This is soft elastic cup. And this is for vaginal birth, a straight pull. And this is for cesarean. I can angle it any way which I want. Compared to vaginal birth, vacuum here is different. Here in vaginal birth you would apply it here, whereas in cesarean section it is applied in front of the posterior continent. And here we are only splitting the fetal neck and direct pull onto that. Deeply engaged head. It is either too longer trial. I have mentioned here vaginal CS. Once I was called in an emergency to signatories, they tried long for vaginal birth, forceps was done, episiotomy was done, and then they decided for a cesarean. They did a cesarean, and then they failed the uterus and got detached. So, call was made, I went over. Then I could realize that what was happening was, it was a very long trial. The lower segment was overstretched and they pushed the bladder very low down. So anterior wall of vagina was cut and from there the baby was delivered. So after delivery they felt the cervix and uterus everything is on the upper side. So uterus is not detached. Once we could identify, it was very simple, a transverse cut of vagina which we had to shoot. So too long a trial. Don't push the bladder too far down because the lower segment has stress and put your incision. Push from below, again very interesting incident. I was spending time in Germany, Kiel, for endoscopy in 2000. And Mrs. Mandler was the chief of endoscopy. But there, everyone had to attend emergency. So once she was asked to do a cesarean, she asked me, "Will you assist me?" I said, "Okay." So when I went over, the patient was in utero. So I said, "This is unusual." So then I said, "Why?" I said, "But we always do it with legs straight." The knee was coming in between for me to assist. She said, "But then how can you push the head from below?" So there, all cesareans were done in utero. Okay. So you can realize when you look at different people, and that is the place where fancy itself was living for 25 years, from 1875 to 2000, somewhere. So it was such an old institution with such a long history and traditions. So what I want to tell is that people use different methods. Endpoint is good outcome for the patient. So by now we have avoided pushing from below because data tells us there is more harmful both to the mother as well as to the baby. Forceps or very single layer of forceps, perhaps someone might have used in these times. By and large, this was given up, but now it has come back. Some company has designed specialties. I am very fond of forceps. My thesis was also forceps. But by and large, I have moved to vacuum, but in deeply engaged area, I go for Butterworth method, the pull from above. Sometimes you can give IV nitroglycerin, 0.25 to 0.5 milligram bolus. You have to convince your anesthetist that effect will last only for 20 to 30 seconds. But in that short period of time, the uterus will relax a little bit. You can pass your finger below the head. Once the gush of air goes down, your head will be descending. So deeply engaged head, semi-lithotomy position of patient. The Whitmore's position, I will show you in the picture. Patwardhan's maneuver, push versus pull, and now abroad people have developed these head disengaging devices. So Whitmore's, the thighs are abducted and externally rotated. This way, the pubic symphysis opens up little bit. It will give you 1 centimeter extra so that you can pass your hand below the head. Or ERR sequence, where what you do is you keep pushing the lower edge below the head. Not your hand between the edge and the head, but keep on pushing the lower edge below the head. Till your hand is also, fingers are also going with this. When this you can use like this and use the pubic symphysis as a fulcrum to lift up the head. And as I said, compared to this is better. So you should pre-decide. You should know where is the bag, on which side is the bag. So pass your hand on the opposite side so that you reach the foot quickly. And you can see there are many studies, head pushing versus reverse sleeve extraction, cesarean fetal head deep pelvis after prolonged obstructed labor, a cesarean technique variant, reverse sleeve extraction. So many studies have shown that reverse sleeve extraction, or what we call as Patwardhan's technique, is superior to pushing from the vagina. And IV nitroglycerin also, as I talked to you about. Now, interesting thing is the RCRG did a survey of senior residents, senior registrars, who are the first call attendant of the patient. And they say that most of them were uncomfortable delivering a baby at full dilatation. So that was deeply engaged where they were not comfortable, and that brought into practice that senior consultant has to be present whenever a cesarean is done at full dilatation. And that was published in British Journal. And they started developing new devices for that. This is a head disengagement device wherein a folded disc is pushed below the fetal head and above the pelvic floor. And then you inject saline in this. It lifts up the fetal head. Their data says 3 centimeter lift is achieved. I am not very convinced, but we will see once it comes to reality. Still not available. People have also developed snorkel device. This is put between head and vagina, and air is pushed. We all know that once gush of air goes below the head comes up easily. Fetal pillow has been designed. So various things have been designed. The ultimate aim is pushing up the head. But as of today, to my mind, the paternal method is the safest. Or else you can pass a blade of forceps below the head and use it as a fulcrum. That brings us to another issue. Baby delivery is not an issue, but closure of the issue. Sometimes, after a long trial, there is a too thin lower edge compared to upper edge. Thickness is different. And we are worried about the next cesarean, what will happen. Both edges, they are very thick. It is not difficult, only thing you will use a lot of suture material and closely placed sutures and scar extension. Now, see, whenever you find the lower edge very thin, go behind and see. Here in this case, this was very fibrous thin edge, but muscle was here. So always try to find good thickness of muscle which is behind. See, that is where the actual muscle is. That was all the heavy fibrous tissue. And then we can see the cervix also there down below. Either you can cut away this tissue or involve them in your suturing. Okay. Otherwise, if I just do an edge-to-edge suturing, this is going to be a difficult case for the next cesarean. If you find this cavity of two edges, this is the way to deal with it. You pass your suture in the upper edge, come below, come out in the lower edge, re-enter and come out. This will fold up this edge and two thicknesses will match. If your bladder is very close, then pass your suture above the bladder for whatever little muscle in there. Re-enter partially with the muscle from inside and go out and tie. So this is you have to dissect the bladder. If the bladder is very much less bladder, otherwise you can always dissect it and go for the thinner part. Scar extension is very easy. It is from the posterior ribs. Whatever you see, take a stitch, pull it immediately, take another stitch. Don't try to find the angle. Many times the blood is there, the ball is coming in, and you find it difficult. And blindly taking stitches, sometimes people have taken greater there. So always keep pulling the scar manually, and when you reach the angle, take the suture. Previous cesarean access we have discussed. Bladder can be a problem. So we have seen that bladder is more dense in the middle part. The edges are where you will find you can go below the bladder also and try and descend from below and then cut away a little bit of uterus along with the bladder. Slight reduction in the length of the anterior wall is not a problem. And that way you remain safe. And so prevention at first yes is most important. Avoid dissection of muscle from the sheath. Once you do this, second time you will have a very adherent muscle with the sheath and strong dissection will be required. Dissection of bladder is to be avoided. Nowadays what we do is, we do a cesarean, we used to push the bladder down as much as possible. Now what we do is we take that 1 to 2 centimeter of peritoneum above the bladder, cut that, and again through that only we do the delivery. Your retractor will give you sufficient opening in the area. So dissection of bladder once you do not do, this bladder will not walk out. It is in its normal position. But if you then start suturing the peritoneum, the visceral peritoneum, what you are doing is you are shortening the visceral peritoneum. And so the bladder is pulled up. Then it is overlying the scar and it will get added. So two things, no dissection of bladder, no suturing of the visceral peritoneum. This way the bladder will not be a problem in the subsequent cesarean section. And uterine muscle we suture non-locking continuous suture, the synthetic absorption.
So as I said, this is a sort of mistaken diagram. Anatomically, we have seen it hysterectomies. Where is the bladder? Anteriorly, only covering the lower half of cervix. The upper half of cervix is not covered with the bladder. So, if you descend the bladder down and put your incision, you are doing a cervical cesarean, not a lower cervical cesarean. Okay. So, one word about locking. We have always locked the scar before, but now we avoid. Here I am just showing the effect of locking. What happens? Here there are 2 points of good contact where the suture is found. The middle part pouts up. You can see them. Then I am just removing the rod. And see that bulge is gone. Okay. So now data is there that locking produces multiple points of high contact, but in between there will be a weaker area. And our purpose in cesarean is not very tight closure of the uterus. Our purpose is only good coarctation of edges and impostures. Because uterus is retracting. If you look at the uterus after just 1 day, the sutures are all loose because the uterus is reduced in size. And second thing is, when you lock and pull, your distance of say 1 centimeter becomes 8 millimeters. Slightly the ends come nearer. Now if you take 10 bites in a full suture length, then your scar of 10 centimeter becomes 9 centimeter. What is the outcome? The uterines are pulled anteriorly, because anteriorly you are bringing the scar near. So subsequent cesarean, you have a higher risk of extending your scar into uterine. And observe this also, previous cesarean hysterectomy. You will find uterine slightly anterior compared to those where there was no cesarean before. And in fact, we are planning a prospective trial on this, where ultrasound interuterine distance and looking at it when there is locking and then when there are no locking. Skin closure, I personally have 2 ways of doing it, but subcuticular only in thin patients. In obese patients, we go for 3 sutures like this. 1 in center, 2 at the edges, and after 48 hours we remove this 2. The central remains. Patient is discharged. After 1 week, this central one is removed. I learned this from Dr. Michael Starr, who developed the Misgam technique. And of course, I was also worried, how can this be, this will open up. But I attended his surgery. We had called him to Ahmedabad a couple of times to give live workshops. Subsequently, I started doing it, and I also found that this is not a problem. Simple thing is, patient again will be bending forward. The scar will not open up. If she is going to go backwards, then only there is full numbers. Okay? And the purpose of removing the lateral stitches is, all the nerves are coming from lateral to medial. So that nerve pressure is taken off. So postoperative pain is minimal. In this way, and only this was done in Madurai workshop we had done cesarean. Patients touch their toes at 4 o'clock in the afternoon. In the morning we do a cesarean and we remove the catheter. They touch their toes, so the mobility is established, and we remove those lateral stitches at 48 hours and discharge them. So in conclusion, I would say that floating head, let like a dream, use oxytocin, follow the foot, or use vacuum arms. Deeply engaged head, semi-lithotomy position, use vectis, push from below versus reverse bridge extraction. I personally prefer the reverse bridge extraction. Use nitroglycerin sometimes,
disengaging devices. Obese woman, incision above the penis, pull down the penis, avoid vertical infraumbilical incision, can consider supraumbilical incision, and emphasis for training of resident doctors in deeply engaged. That brings to one more issue of cesarean section in adherent placenta. This is a big issue by itself. I would just go through it very quickly, just few points of doing cesarean in this particular problem. Of late it is increasing, perhaps it is because more and more cesareans are done and more repeat cesareans. Data tells us that if today CS rate increases by say 10%, the placenta acuita rate will increase after 6 years. Because this generally will go back for another 6 years after 6 years. Type 1 is easy to handle. There is a space between bladder and uterus, and placenta is confined to uterus. It is not going beyond the uterus. Type 2 is it is going beyond the uterus, sometimes maybe adherent to bladder, but there is space or give. You pass your finger and you can see that there is a space. These are also slightly easier to handle. These are tough ones. Bladder is densely adherent to the uterus. I would just switch to the surgical management. Separation from surrounding structures, delivery of the baby, resection of the scar, repair of the defect, hemostasis, uterine sutures, vessel ligation, either uterine artery or internal area. Hysterectomy many times is required. Planned hysterectomy with placenta in situ if future pregnancy is not desired. Incision of uterus based on patient's body habitus, midline vertical or transfundal incision if type 2 placenta. Avoid spontaneous placental separation. Always go for, S2 segment I need to speak to you about. Always go for total hysterectomy if S2 segment is covered with placenta and deep dissection between bladder and vagina is required. Now, if your bladder is densely adherent, your vessels are going inside the bladder on ultrasound or covered on your MRI, cut open the bladder deliberately, because that way you will know how far you are from the ureteric orifices. Then dissect the bladder from uterus. It will be much more careful dissection and you will not cover this area and subsequent issues. These vessels, the new vessels which are formed between uterus and bladder, do not have muscles. And so, cautery will not work. If you use cautery, you need protein there which will coagulate and stop and close. Here, identifying and ligating each will be a better option and separate from the bladder. Fundal delivery you can think of if placenta is going and covering the cervix also. Leaving behind the placenta can be a deliberate decision if bleeding is not much. You can leave behind the placenta after 2 days, the placenta may get separated and pull it down. But Dr. Arun Kumar and his team has developed triple P procedure to preserve the uterus in placenta acuita cases, and they have given 3 points. Triple P procedure, perioperative placental localization, and delivery of uterus via transverse incision above the upper border of placenta. Now, placenta can be going on the interior wall. You go above that level, so ultrasound location of placenta becomes mapping becomes important. Deliver the baby, then think of pelvic devascularization, so internal dilation or uterine dilation. And placental non-separation. Don't separate the placenta, but the entire area of muscle covered with placenta, we just cut it out. So the anterior wall will not be there, and suture uterus will be folded, but it becomes normal afterwards. Slightly reduced anterior wall,
but doesn't matter, this uterus can have another pregnancy. And this particular paper from Russia, they have successfully using this technique, and they have found great success of saving the uterus and achieving pregnancy. One word on this I am propagating in Ahmedabad also. Placenta acrita, I think one slide is missing. The lower segment uterus supplies blood from 3 vessels other than uterus. Okay, one is superior vaginal artery, one is vaginal artery, and which is the third. So these vessels are not branches of uterine, so ligating the uterine or doing a subtotal hysterectomy will not stop. Here you have to do a complete full hysterectomy, because why I am saying this, recently I had to attend a case where they did uterine artery embolization, and they went up to the vaginal artery also, 18 units of blood, and still patient kept on bleeding, and then we had to surgically treat that patient. So lower segment bleeding, one has to be very careful. Simple uterine dilation will not work. Intra is the better option. And these cases should be handled in a tertiary care. Nobody should take it up in a small nursing homes. So even American College of OBGYN has identified in their patient safety series Center of Excellence for Placenta. And they have put up to the extent that if you open the abdomen and if you find placenta, because 30% of acrita are not diagnosed by ultrasound, they are missed by the most experienced person also. If you open the abdomen, you find placenta acrita. If you have a facility, blood, hematologist, urologist, general surgeon, then only you ICOG. Or else close the abdomen, shift the patient. You yourself may do it, but go to a place, a personal excellence and capacity is not adequate. You need a support system. So if they go to this extent, we also need to take it very seriously. Okay, the S2 segment slide is missing. You should do an MRI whenever there is a placenta in lower segment, previous cesarean. Then likelihood of acrita is very high. MRI at 30 weeks, partially filled bladder, about 100-150 ml filled bladder, and you draw a line perpendicular to the bladder dome, and if your placenta is going below that line, that is S2 segment placenta, requires tertiary care. If your placenta is above that, I find the picture and show you. Then you are justified in handling that patient. And then I would like to just share a very interesting case. At many places I have shared this. Jose Palacios from Argentina is a good friend of mine. He has done excellent work on BPH. He has done post-mortem of 35 cases of BPH deaths. And he wrote a paper on blood supply to lower uterine segment. He shared with me this case. This is about 10-15 years back. The dear Parul, I would like to comment this case with you. He's a Spanish person and his English is like mine, so please bear with the language. It is obviously a consequence of uterine scar divisions following cesarean section. Patient 31-year-old, 2 previous years, 21.5 inch pregnancy, anterior placenta, lower abdominal pain in morning. Her doctor didn't notice nothing abnormal and requested an ultrasound, informed normal. Early time she was paid with hypotension. Her doctor thought a kidney infection and was admitted in hospital. At 1 a.m. she was hemodynamically unstable and a laparotomy was performed. Massive hemoperitoneum was discovered and he called me an emergency because he detected an anterior placenta percutaneous source of bleeding. When I examined the surgical field and after moving the bladder, I saw this view.
and a source of bleeding was detected in the edge of placenta, what would you do? I really appreciate your opinion. After that, I send you my solution to this case. So this was this picture. You can see placenta percreta bleeding from this. Now, I wrote to him that I would deliver the baby. If patient is stable, if she is desire of another pregnancy, then I would repair this. Otherwise, I would offer a hysterectomy. Then he wrote back, no, this pregnancy is also important. So what he did was this. He sutured all the blood vessels by bursting stitches. And then put a mesh which was over the scar attached to the upper part and below the below the scar in the normal. And he allowed the pregnancy to continue. Every 2 weeks he would send me MRI pictures, and at 34 weeks he did a fundal cesarean, removed the mesh and repaired that. So I wrote back to him that who else did you ask for his opinion? Because I was really wondering that I never thought of this. He sent me some 15, 16 responses. None of them was from India, but some from Europe, Japan, various. Barring me, only one man had talked about retaining the uterus as a possibility. All the rest had said hysterectomy dietary. And this man could think of this, and he was successful. This case was published in British Journal subsequently as a case report. So, we had an AICO in Guwahati some years back. 10. And the organizing committee asked me, can you suggest some good speaker from outside? And this man we had called. He had come and he did present his material, his paper. I asked him that, how could you think of this? So he said, the husband of the patient was a cardiac surgeon. And he, when I entered the OT, they were Roman Catholics. So they were very anxious to salvage the pregnancy. Can we do something for this? So they said it is risky, but they said we are ready to take this. So he did this. And you see, years back, I had discussion with a physicist, and he told me that when you inflate a balloon, if there is a rent at the top of the balloon, and if you put a patch there, when you inflate, the patch would come off. But if the patch and rent is in the lower part of the balloon, if you put a patch there and if you inflate, balloon will inflate. The maximum pressure is taken by the top, lower part doesn't take it. He said that thought was there in my mind, and so I did it in this case. So this is just to give a stimulus to our young students, that always think out of box and try and fulfill your patient's desire. This patient's desire was to salvage the pregnancy. She was ready to take risks. In those situations, if you can do something for them, it is worthwhile. Well, I have put it up as an article, difficulty in delivering babies at cesarean, in one of the textbooks. Thank you very much. Please share your own particular issues. The next part was, shall I go ahead and discuss later? How Dr. Ananya has already covered the rates of cesarean. I'll just share the medical tips for that. Well, I bring you greetings from the opposite end of India. We are actually 1.5 hours behind you. If we look at the sun comes up 1.5 hours later than what you can. So why are the rates rising? Is that a problem, short or long term, and strategies to reduce the cesarean? This is all history. But historically, cesarean was very risky, and it was an operation of last resort. This was a paper published in 1898, where the data was that Craniotomy, mortality of mother was 20%. Cesarean, 89% in 66, 84% in 1876. So you can realize that the patient herself would die even on the baby. And so we used to see in old movies, doctor would come out and say, I can either save the baby or the mother, you choose. And sometimes women used to give the sacrifice of their body, then let the baby live. Anyway, we have come a long way from that. In 1853, anesthesia was introduced, and it was initially people were reluctant to take anesthesia. But once Queen Victoria herself used anesthesia, it became popular. 1870s, again cesarean was quite crude, and people used to never use suture ureters. That was the big problem. 1876, Edward Burrough first time removed the uterus at cesarean, and then attached the wand to the anterior abdomen. Right? He saved many patients. 1882, first time suturing of uterus came into being. Then Lister brought in disinfection, penicillin came, antibiotic, and lower incision came up. Then oxytocin was found in 51. So what evolved over time? Incision over abdomen, lateral to vertical, midline, and low transverse. Incision over uterus, fundal to lower segment. Suturing of uterus, from no sutures to removal of uterus to suture non-absorbable, then biological absorbable. We all used catguts in our student days, synthetic absorbable. Infection control, hand wash, carbolic acid, asepsis, antibiotics, anesthesia and pain relief. All this increased the safety, but the outcome was high rates. Because now we were doing cesarean much more easily. So this is the US data, 32.1% delivery of US by cesarean delivery. And our Indian data also is about 22%, 21%. Cesarean is now more common than episiotomy. This is something hard to digest, but it is fact. Indications are changing, and it has become an operation on demand from operation on last resort. So this is NFHS data generation from 1992 to 2021. In a span of 30 years, the cesarean rate has grown 10 times. Okay. Of course, this all Dr. Ananya has talked about. Jharkhand is very less, and Tamil Nadu is very low. But believe me, this is not India. All over the world, cesarean rates are increasing. So we cannot blame ourselves that we are something wrong. Why globally it would increase? All developed countries also have very high cesarean rate. China has almost, it is touching very, very high. China and Brazil are the topmost. Somewhere around 60-70% is the cesarean. So something is there is some logic also behind that. But interestingly, Israel, Finland, Sweden, these countries are very low rate. And still, the data of perinatal outcome is superb. I still remember, in India, the southern states have the highest rates compared to other states. But isolated like J&K, Bengal, some parts of your area, here in Gujarat, in Maharashtra, it is high. Now what would you all feel? She did talk about 15% cesarean rate. Is that ideal, anything less than 15? Or would you feel 15 to 25 is good? 25 to 40, 40 to 60, more than 60. So we are few here, but please raise your hand. How many of you profess less than 15% in your own practice? 15 to 25, 25 to 40, please raise your hand. Which one? 25 to 40. 40 to 60 and 60 plus obviously no one. So I believe that most of this group are somewhere around 25 to 30, isn't it? So do we feel the need to reduce. Sometimes we do, because the medical college where I am attached in Andhra, I was there, the cesarean rate was 60%. So more cesareans than vaginal birth. And I still remember my daughter was studying in that college, and she said, I have not seen a vaginal birth, I have seen so many cesareans. Because vaginal birth happens only night, when no doctors, seniors are available. Daytime, everything ends up in cesareans. So that was a very interesting feedback from an undergraduate student. So WHO data, although it was from 75 countries, people were there, but this was in CS rate of more than 15% of no additional health benefit, but we have now questions on this, and it is globally questionable that in selected patients you may. Like my personal cesarean rate would be hovering around 60%, but most of them are referred cases. My ex-students have sent it to me. They are definitely placenta acrita, they would send me. Obviously, there is no chance of that. And what sir used to say was very correct. In young age, we were overconfident. Not only confident, beyond that. We were ready to take anything, and we were discussing that we have done hysterectomy without anesthesia, the local, which I would not dare to do. So with maturity and with the scenario in the community, now patients are not ready for multiple pregnancies. They either want one or maximum two, so they do not want to take any risk. When we share with the patient that previous cesarean, shall we go for vaginal birth, you have only 2 to 4% chance of scar rupture. They will say no. And then we are duty bound to follow that. Similarly, slightest fetal distress, they are sitting there and the sound is heard by the relatives. Now they say, doctor, baby is fine. How can we say, no, it's perfectly fine? So those are situations which force us into legal scenario. Unfortunately, not a single case that I am aware of where case was that unnecessary cesarean was done. Then all the cases are no timely cesarean was performed and baby suffered. And that is why that legal pressure is also indirectly working on our mind. So problems of high rate are 10 times more BPH, bladder trauma, ureter damage, bowel damage, more antibiotic use, more blood transfusion, longer stay in hospital, post-op pain, additions, delayed in oral intake, breastfeeding, ambulation, more neonatal transient tachypnea, lung problems, cuts, asthma, and nursery admission. So higher risk of repeat cesarean section, placenta acrita and obstetric hysterectomy. 90% of placenta acrita end up in hysterectomy. Maternal mortality rate with CS is 3 to 7 times higher. Infection, DVT, pulmonary embolism, especially with obesity and diabetes. Endometritis incidence is much higher compared to vaginal birth. Postoperative depression and of course costs. Now, this is old data from US and UK. What you see is vaginal birth, maternal death was 20 per million. Elective cesarean 58 per million. Emergency cesarean was significant, 182 per million, 9 times more. So cesarean has its own issue. And couple of new interesting thoughts have come. They have found that hematocrit in baby is also lower in babies delivered by cesarean. I have not yet figured out why this is so, and this is another interesting thing. What happens is that cesarean babies have altered epigenetic profile, and so if you store their stem cells, even those stem cells will be not normal, and that is why we present the first evidence of association between delivery type and degree of DNA methylation of specific genes in offspring. And they are talking that altered epigenetic profile after CS may pose concerns for umbilical cord blood bank for later transplantation. So there is something which is coming up, which is very shocking and very new. So as long as possible, don't deviate from normal things or natural things. That is what we can say. Now, argument about better less perinatal mortality with cesarean. Yes, at 15%, you can see the perinatal mortality is high. But if you take it to 20%, the perinatal mortality goes down significantly. So, contrary to WHO, you can help babies at least, and perinatal mortality goes. But beyond 20%, you rising so much higher, but the perinatal mortality is static. So anything beyond 20 as of today is not for the baby. Then you can think of indication for the mothers. Now why rates are rising? Convenience. Of course, we are all humans. Time, staff availability, neonatal. My neonatal always grumbles if I ask him in the middle of night cesarean. He would say, why don't you do it in the morning time? We are all fresh. No risk approach by both families as well as doctors. On demand, fear of pain, auspicious days, another element which we have to face. Sometimes they ask for some odd times. The baby has to be delivered between these hours. Litigation fear. Then maternal conditions are also now increasing. More than 35 age, obesity, 15% plus patients are overweight. Diabetes and IVF pregnancy. All these were not there before 15-20 years. They have come up in last 2 decades. Obviously, most of them end up in cesarean. Fetal conditions also, now we salvage babies, we take them up to maturity and then do a cesarean, which would have otherwise died inside. Costs, income, doctor hospitals are greedy are all the media and politicians projected things, and which we need to as community counter. So time and convenience are two crucial elements, and global data tells us that highest rates of cesareans are between 8 and 10 in morning and 4 and 6 in the evening. Why? Because that is the time when the consultants leave the hospital or come to the hospital. It is not our data. From Greece, from UK, it is a global data. And as I said, we are all human, so human fallacies and human weaknesses are going to be there. Genuine medical uncertainty about health of fetus. Ultrasound person tells you the blood supply is altered, then we are worried. Cord rounding, we are worried. We can't guarantee patient that everything is 100% fine. Charges, I can share with you my own experience. I joined a corporate hospital in 2006, and we proposed that at 6 months, patient has to choose. And we said there will be same charge for either vaginal birth or cesarean, which was less than cesarean, more than vaginal birth. After 2 years, not a single patient opted for it. If they were thinking that we can save money if cesarean was done, why didn't they take it? Okay, so it is a wrong argument. People put it across. Somehow they are always grumbling when there is an expenditure. But we did put this for 2 years, which was about 20% less than cesarean section and about 30% more than vaginal birth. Not a single patient opted for that. Only rider was at 6 months they will choose. After 8 months, anyway, a doctor has told them this is going to be a cesarean, then they opt for that is not acceptable. And second interesting fact was in that hospital only, one doctor's delivery I had to conduct. Doctor's wife she was, and the nurse never pressed onto the perineum. 30 can happen, and I scolded the nurse. Why did it? She said, "Sir, this is the first vaginal delivery in 3 years. I didn't know what to do with that." So such is the situation in corporate world. Now some strategies. Analysis of indication, Robson's criteria, I do not agree with Robson too much, but I agree with one thing. He brought a thought that you should sit down, you should in your hospital analyze your data and do something to reduce cesarean safely. Ultimately, safety has to be paramount. And focus on 4 common indications is what I suggest. Mandatory second opinion, reverse competition, increase support and pain relief during labor, because even in most corporate hospitals, epidural is not available. Patients are worried about pain, and above all, the biggest quality of a good obstetrician is patience. So in our hospital, these 4 were the commonest indications. Previous years, fetal distress, breech and CPD, this would be 73%. If I work on this, I may reduce it by 1-2%. If I work on this, there will be a significant change. Similarly, WHO global survey in 9 countries in Asia, these 4 contributed to 80% cesarean. Previous years, CPD, fetal distress, breech. So if we focus on these 4, and develop strategies for this 4, you can make a big change. So vaginal birth after cesarean, by and large, it is given up now. The best thing you can do is, there have been different scores developed that if you follow this score, safety is increased. But you try and reduce the primary cesarean. The first delivery, if you avoid cesarean, subsequently you are always going to CPD and fetal distress, good clinical practice, use a partogram, give time. Prolonged second stage is not a problem if mother and child are good, you can wait further up to 3 hours. Judicious use of oxytocin. But more important are general measures, hydration, free movement during labor, intermittent auscultation, rather than asking the patient to lie down with a delta around. To prevent one death in breech, 29 cesarean would be performed. Very high maternal morbidity in cesarean. So between normal weight, I would not call it 1.5, 2 to 3 kg birth weight, no benefit of cesarean. More birth weight or less weight, you are justified. But I personally feel that do an ECG. Because once I changed the medical college, I went to another one. In the OPD, I tried to perform an ECG, external mechanical. Suddenly our call went up. 20 residents came in. They said, we have never seen a ECG. Now this is very sad. All of us should learn this very simple technique, and one successful ECG will be such a great thing for the patient. Treatment of cervix with high days can soften the cervix. Active management of labor reduces cesarean significantly. Doula support and Swedish experience. I was attending a conference on labor in Mumbai, 1995. I believe Dr. Tan had it. And I was chairing the session, and a Swedish person was talking. He said, if we reduce the cesarean rate by 1%, we can save so many million kroners. So they developed a strategy, and they reduced over a period of 5 years, 3% cesarean rate. From 12% they went to 9% in Sweden. So suddenly Donald Gill, who was from UK, he's fetal partogram specialist, he said, what is the trick? We have not been able to do it. So this man said, what we did was, we divided cesarean into 50 segments. 2 with highest rate, 2 with lowest rate. Monthly meeting, they go on the stage. Then they discuss. They would say, what is the outcome? This person can justify having more emergencies, more this kind of cases. But then they would say, okay, your is high rate, here is low rate, outcome is same, baby's survival is same. Nobody would criticize anyone. They would say, oh, your explanation are excellent. But he said, when he goes back and he performs another cesarean, he will start thinking, can I avoid this, otherwise I have to go on stage again? Okay, so this was a peer pressure kind of thing. Automatically he would start avoiding. Similarly, those who come on the stage again, he would start thinking. And that is how they brought it down. So reverse competition, even in a medical college, you can do that. 1 unit with highest rate, 1 unit with lowest rate, monthly discussion. So 2 clinical intervention, ECG, we do not push much. 1 psychosocial, 1-to-1 support during labor, mandatory second opinion. 7 countries in South America joined hands and they did this prospective trial that whenever I decide that cesarean is necessary, he will be asked independently, he will assess the patient and he would agree then cesarean, otherwise continue the trial. And they could reduce the cesarean rate by 7%. This article was published in Lancet subsequently. Mandatory second opinion. So that those are various things which you can do. And now there are other pressures also, which I would like to share with you. Not medical, but pressures. This particular article published in BMJ, British Medical Journal, the conclusion was the result supports a policy of offering healthy women with low risk pregnancy and choice of birth setting. Women planning birth in a midwifery unit or multiparous women planning birth at home they experience fewer interventions than those planning birth in an obstetric unit with no impact on perinatal outcome. So when for multiparous women planned home birth also have fewer interventions but have poorer perinatal outcome. So what they projected was this: home delivery, midwifery unit which is independent, midwifery unit with a doctor and all doctors setup. Regional anesthesia 40, 60, 121, all out of 1000. Episiotomy 23, 35, 56. Caesarean birth 8, 10, 35. Instrumental birth 12, 23, 30. So you can see everything increases, all interventions increases when doctors are there to deliver them. And then New York Times picked up this and they say that this was NIH data, that it is safer for healthy women with uncomplicated pregnancy to give birth under supervision of midwives than in a hospital, maternity unit run by doctors. And they are saying doctors are much more likely than midwives to use interventions like forceps, spinal and cesarean section. Then in Harvard, Neil Shah, assistant professor, conducted a trial and his outcome was cesarean is a major surgery, 3-fold greater rate of serious complication. But ultimately what he said was obstetricians are hardwired to operate and too many operations are harmful to the patients. One strategy to fix this might be to change our wiring. Another way is the British refer patients to stay away from obstetricians altogether, at least until you need it. So you can see that from other factors, non-medical factors are now pushing us to avoid cesarean rate. So in summary, I would say these are the strategies which we can employ. Focus on 4 commonest indications. Audit. Robson's criteria are not necessary, but your own audit you should develop. Mandatory second opinion, avoiding first cesarean, pain relief, peer pressure, Swedish experience, selecting the caregiver, doctor or a midwife, cost parity, avoiding the on-demand, and punitive action. Now, punitive action is something which we all may not agree, but look at the costs of cesarean versus vaginal birth. Cesarean, all countries. And the last nail in this is this. In California, one insurance company has recently announced that those hospitals who will have more than 24% cesarean section rate, they will not be covered by insurance. Deliveries in those hospitals will not be covered. So this is very soon our insurance people are also going to pick this up. So we have to be conscious, and I say this: wake up, put in place a strategy to reduce cesarean rate, bring the cost parity between cesarean and vaginal delivery, conduct large surveys, and document patient demands. Always write it down. The patient insisted, hence I am doing this, and produce that data. Highlight this in public domain. Politicians, media, people are all against us, it is time to protect ourselves because 15% is never going to happen. We have to accept that. We have to be pragmatic. And if we do not do anything, another PNDT is doing, as somebody said, you have to go to a medical college professor and get an approval, then only you can do a cesarean. That kind of a thing is also coming up. So avoid that. But of course, if your door is tied, you do not break the roof. Similarly, whenever vaginal delivery is possible, please go on and do that rather than going through the roof. Thank you very much for patiently listening. So
thank you very much, Dr. Farun, for your excellent oration. I am sure we have all been benefited on the technical difficulties of the cesarean section. You have shown the way out very, very, very vividly. And of course, how to reduce the cesarean section rate. We are running out of time, but I'm sure almost all the audiences have questions for you. So I think a delay in another 15 minutes is going to benefit us a lot. So I open the house to questions. Please, anyone like to?
please.
I'll be surprised.
Might be having a lot of questions, right? Please come up with your questions.
No, there was a raise now. Yes, please.
Sir, what are technological innovations we can bring to reduce the cesarean rates?
No, I will share with you all the strategies. So which particular thing do you have in mind?
Any kind of chemical or any technological way of reducing the
No, as of today, whatever I shared with you, the various strategies of second opinion or say audit, learning from others that how they found a way out, and we implement that in our practice. That will happen. We do not have a new machine which will come up and then, yes.
I just want to say that in my practice, like I've seen that my cesarean rate is high because most of them are either previous cesarean or previous two cesareans. So I think the best way is to prevent the first cesarean. That is the best way out. Because there only we have to be very careful. Because my pregnancy and cesarean rate is high because of that. Most of them are previous two cesareans. They want so then there is no question.
I actually just heard this sound and one of you were saying something like baby development AI, where you put all the inputs, and this AI will tell us whether she really needs a cesarean or not. So that is the future of obstetrics. I don't know. I heard it in some conference.
AI has those two fingers. They are not big. And AI, she is in a medical college. And like they have such a high cesarean rate. And when she sees me, the way I stretch the cervix, the way we do it, she says, we have never seen them doing, doing a crazy that. Like they just say, like, okay, one finger view, that's it. And we see them stretching those cervix and we don't deliver. So I think AI is not very good.
No, see, the problem is each patient is different. Okay. So we cannot generalize. We may say this is possible, but in that patient we need work or not only time. Yes.
And in fact, we have been there so much. So that is,
So I have two questions. One is, so the increasing rates, is it also because we are facing more patients with comorbidities and complications? Because now I have very few patients who don't have any constant diabetes, they have the hypertension, they have patients with, of course, diabetes, and hereditary diabetes. So the tendency for me is to obviously reduce the burden. have reached 29 weeks, that's great. But there are some where I probably have to wait 38 because these are so high, sugars are uncontrolled, and there is really a clash in these cases. And for me, I found that these are the main factors that increase my CS rates. Second thing is ethnicity. Yeah, does ethnicity have a bearing? Because what I have found, I did my MBBS at Rajasthan, then my post-graduation in Bangalore, and then came here just about 7 years ago. So I have seen obstetric cases, and what I found here in Meghalaya is that something about the musculature of the uterus, we don't have uterine lapses, even though we have patients with very high diameter. We have the trend where we still have patients with G7 and G8. We have G15, G21 also, but we don't have relapses. In fact, 7 years of academia, I've only seen one cascade with the relapse, and that was 2 weeks back. So does that also have a bearing on the CS outcomes? Because we also have high CS in the sense that we have patients who come back with the 4th CS or the 3rd CS. The other day, 2 months back, I had a patient who got pregnant of 5th children and 5th CS. And so, just the
Your observations are, I think, that we are getting this kind of diabetes, hypertension, old age pregnancies, high age pregnancies, where the pressure is more to avoid risks. Regarding prolapse, although it is not pertinent to cesarean, there is very simple. Over the period of time, genetic changes happen. Initially, it is lifestyle. Now, it has been observed that South Asian people, the Indian people, generally their food intake contains a lot of oil. And that leads oil and spices, that leads to chronic constipation. Similarly, South Europe, Greece, Italy, France, also have prolapse. But Northern Europe doesn't. Similarly, Arab people, they have multiple pregnancies, they don't have prolapse. Arab women, I was discussing once with an Arab doctor, and he was asking me, he was interviewing me, then, doctor, how many cesareans you will perform on the same patient? I said, here in India, generally we have 3 weeks now. Generally we have patients in our problem. He said, anything less than 7 children in Arab family is a social shame. So you have to do so many cesareans if required. But in general, Arab women do not have prolapses. So this perhaps is over a period of time, things are developed for a community. But essentially, chronic constipation and asthma are the biggest causes of prolapse. Indian women have that. I do not know in this area, do you have food habits which is less oil? That would be the factor. That would be the factor.
I wanted to ask you, because we are seeing a lot of patients with oligohyperemas, which is forcing us, as she said, to intervene early, like, just after the 7 weeks. So is that is that a scenario that is seen all over India, or is it more?
How many of these oligohyperemas diagnosed actually are on cesarean? So many of them have. Okay, so ultrasound has really shaped our life a bit more. They would say that this story is less or that is there. Then many of we do run CBD, some of us directly jump out to terminate pregnancy. So many interventions have come up, and all of them have high false positive. They are not wrong, but high false positive. So many times, although everything is normal, we are given a report which is abnormal, and patient also starts worrying, and we also start worrying, and we end up in a
So I do my own ultrasounds. So I know that it is actually less because when I go in, it's really crowded. So the thing is that
I'm not saying it is not, but half of the time I have also my own findings.
But the thing is that, like, when we induce these patients, we usually, like many of them, I would say, between 57, and then 7. So this is becoming a problem. Another thing that I'd like to share, two cases of difficult cesareans, as we said. I had one who had come in the second stage, and she had a balance ring. When I opened her up, and I saw she had a balance ring, and we had to cut out balance ring, so we had to put it in the teeth. So that is also one scenario which is difficult. The head gets trapped up and then bladder loss for 2 minutes. Then one more difficult cesarean is that recently I opened a patient, so she scanned. There was a fibroid in the lower segment. But when I opened it was just there where I'm supposed to put my incision. So what do we do in that in the fibroid case?
I mentioned the upper edge of it and put the transverse. After delivery, I would take the call. As of today, 90% of fibroids are removed at cesarean. Very rarely I have to leave it out. But after delivery, I have to leave it and take it out. So upper edge, if it is an oblique fibroid, go oblique also, along the edge of that, so that if you require removal, please.
One last question. Do you feel there's a change in the pelvic structure over the years? Because what I have noticed of late also is that I've had patients who want full dilatation and under the GTA, and I have to take it out for some rest. It's increasing even with multis. And I don't quite understand why this is happening.
See, if you look at some diagram, today's mother were born in 1980s. So when we were students, the mothers were 1960s. That was the time of malnutrition. Okay. So their practices were not good. And their babies were fed well. Okay. So when well-fed baby is there, the pelvis is small, this proportion is going to level up. But these babies, now today's time, we are overall nutrition is improved. So these babies, when they grow up, their pelvis will be okay. So maybe 10-15 years later, you will find that pelvis is not an issue or cesarean. Other issues may be there, but CBD will not be an issue. And we all know that during development at what stage the pelvis, each wall gets pressed and how the shape of pelvis alters. So those things are there, but biggest thing is nutrition young age, when the pelvis is being developed. At that time, the good nutrition is offered. This pelvis is good, and then the delivery will be simple.
So is there a role of exercise in this, which is anti-aging, or aging vaginal?
See, exercises have 2-3-fold of benefits. One is it gives positivity and confidence to the patient that I can do it. Okay. That is the biggest plus point. Of course, muscle strength is important, but more, I would say, is relaxation during labor is important. The pelvic floor, she needs to relax those muscles. So, contracting abdominal muscles is important. We generally teach them 4 exercises: abdominal one, the back. Back is because later on back is a complication. Third is breathing, strong breathing capacity. Fourth is pelvic floor. Pelvic floor for relaxation. After birth, strengthening. They have, I would say, medically speaking, limited value, but overall positivity effects about confidence within a person also is. Yes.
So since we are talking about reducing the cesarean section days, so do you think these 2 indications which I mentioned, we can try to revive that back versus breech delivery? We are taking breech for cesarean, and this is vaginal birth after cesarean, and it is a non-recommended indication. So do you think we should revive our art again, and then this might be a step to reduce the cesarean? Because these are not like it has to go for cesarean, not an absolute indication.
See, in an ideal medical setting, I would say yes. But in context of discussing with patients, there is a problem. Because as I said, if I tell them there is 2 to 5% chance of scar business, they are not ready. We have developed a special consent for previous citizens. They are not ready to sign that. So they sit on the head for all the eventualities. That is the problem. In fact, we underpaid one of our residents, she will Judicious on there. And interestingly, previous citizen for city mentioned in this time vaginal birth is 60%. In those where previous citizen was false. Overall, 70% feedback success was noticed, which was published in GMAT. So that is for citizen. On page, I visited one institute for mental child children in Bangladesh, and I asked them at that time, that do these babies have a history of birth trauma in the sense for sexual children? They said 80%. Since then, my thinking has changed. Vaginal delivery at all cost and excessive. I mean, you can pull out a baby, and that time nothing will be noticed. Later on, something long-term can happen. So don't make an issue out of it. But of course, whenever visible, we can always go for it. But that visit really changed my mind. 80% of mental children in that institute had either pre-delivery or a first. So we have to keep that in mind as well.
So another thing that we do for citizen section and the center area, of course, we try to share the center and organization. Like, do you have any data like of your own going through the placenta, excising through the placenta, staying in the placenta?
I don't know that area. But it is complex and we will start using that.
Yes.
Once you cut the plastic.
We are always trying to stay, but some people are asking they are good enough to go through the placenta.
It is rest. All eyes are confident of reaching the edge of placenta and delivery. Sometimes one will see it very complicated, very like let me cut. I do it very fast, but that fast can take 2 to 3 minutes. A lot of blood has been lost. It is, I personally feel, not appropriate.
Thank you.
Well, I would like to thank Dr. Arul once again for his excellent rendition of this oration. I am sure every one of us has been benefited. And I also would like to take the opportunity of thanking Dr. Ananya Das for organizing this excellent CME. And I'm sure we'll go home much wiser and we'll be able to take home what we have learned this evening and be able to implement it by saving uterus as much as we can and try to reduce the cesarean rate as much as we can. With these 2 words, I end the session. Thank you.
Thank you so much, sir. Now I would like to call Dr. Ananya ma'am to felicitate our chairperson, Dr. Shamdar sir. Our session now comes to an end now, and we are very grateful to all the delegates, faculties, guest faculties who have spared their valuable time to be a part of today's CME.
I'd like to extend my special thanks to each and every delegate and all the faculties present here. It was really a very wonderful evening with a lot of knowledge gained. Thank you so much.
We will now proceed for high tea, which is being served outside the hall.